Are you counting now?
Yes, started. You can start.
Okay. Good evening, everybody. A warm welcome to this TOSI webinar. I, as the General Secretary of TOSI, that's the Teleopton Society of India, am privileged to invite to this webinar. We have with us today the star attraction, the famous Bollywood sign actor, Mr. Boman Irani, to give his address, and who has created, ripples in 2 movies. Everybody remembers Munawai MBBS and the 3 Idiots. And we have with us also a galaxy of speakers, including the National President of IMA, Professor J. Jailal, Dr. Sashibhushan Gogia, ex-chairperson, IMIA Working Group of Telehealth, Dr. Ganapati K., Director, Apollo Health Services and Apollo Telemedicine Networking Foundation, Dr. Ganesh Arun Joshi, CRC Bhopal, Dr. Sunil Shroff, President, Telemedicine Society of India, Tamil Nadu chapter, and of course, Dr. Padmaja Rani, with a VR consultant and in charge of teleophthalmology establishment at LVPI Hyderabad. And I welcome all my TOSI team, including my President, President-elect, Vice President, my colleagues. Of course, without the support of ECO members and their technical team, it's not possible. So I welcome them all to this webinar and all viewers all over the country. Above all, I welcome our president, a dynamic president, Professor Padmasri, Professor S. Natarajan, a great inspiring person who has led all our team members to the successful launching and the mission of TOSI. As you know, telehealth, a gift of corona to the nation. During COVID times, because of lockdown, shutdown, people were indoors, deprived of the basic health care. At this time, telemedicine came into the rescue of these poor people and supported them with the basic health care, giving a smile in their face at the time of crisis. Simultaneously, also teleophthalmology also evolved into a branch of science, and it has reached the nook and corner of the country with the doorsteps of the patients to give at least teleophthalmic consultation in the last few months. But still, the road is ahead. We have to go a long way. The goal of teleophthalmology is to detect basically many eye diseases in the early stages. For example, diabetic retinopathy and glaucoma, which unnecessarily leads to blindness. So probably teleophthalmology, with the help of artificial intelligence and paramedics, can show a light to us. Thus, it will provide a high quality, cost-effective community eye care at the doorstep of the patients in the rural and unreached areas. TOSI is only a 1-month-old organization, but it's moving forward with a lot of vigor and determination under our presidents and president-elects. So in the recent COVID and post-COVID era, it will play a major role in helping the mankind who are shattered physically, emotionally, and financially. So these few words, I welcome all once again to this webinar to discuss the future of this teleophthalmology. Thank you very much. Now it is over to our President, Professor Natarajan, to give a welcome address.
Good evening, everybody. Good evening, ECO India. Good evening, Indian Medical Association, and all the medical fraternity, and also the people who are viewing in the Facebook and YouTube, the public. The reason is the entire webinar is only to educate the people how to use telemedicine, telehealth, and teleophthalmology, and that's the reason we are here. So I like to share the screen, just only 3 slides for the introduction. So my talk will be later, but that I'm going to take this as a diabetic blind free India, and I am talking as a president of the Teleophthalmic Society of India. And today happens to be my grandfather, who was an ophthalmologist, who was from Madurai, and I'm also born in Madurai. And he served also in Ganjam district in Orissa, because Madras presidency extended up to there. He also studied in Madras Medical College and Government Ophthalmic Hospital, my father and me, and also many ophthalmologists from here, including my mentor, Dr. Badrinath, Dr. Tsunami, who was a doyen and the legend in ophthalmology. And so I'm glad that he also started eye camps in the past. And then the reason we are all here today is the Tele Society, along in collaboration with Echo India. We want to promote teleophthalmology during this COVID tsunami. And I think we are in the right day we decided, even though many of my executive members said the time is short. I said, no, we'll take a plunge. I don't know how many are taking part in this today. I hope because we will have it in live in the YouTube and the Facebook. The idea is we want everybody to see, if not today, if not now, maybe later, and use this technology because it's available with many ophthalmologists, many optometrists, and eye hospitals, and maybe all the telehealth group here. That's why we're having experts from Telemedicine Society or Telemedicine Society of India, and we also have extended to Indian Medical Association, where about 200,000 doctors are there. And I hope we have sent this invitation to so many doctors and also the public through Facebook. And so it's not a marketing, it is not any soliciting for patient, but we want patients to be safe. And in the time of crisis, where we don't get beds for the patients who need them, or particularly the pulmonary problems, other than COVID, and also non-COVID problem is being neglected. One of them is a diabetic blindness, and other is age-related macular degeneration pertaining to ophthalmology. But here we have also experts talking about telehealth. And Mr. Bomani asked me, can I talk about vaccine? I said, whatever you want, you can talk. The whole idea is that we want people to understand that Government of India is promoting telemedicine, and they are also legalizing, and they are also having how to give prescription. And there was a question from an senior Optometry Council of India and Optometry Association of India. And the only problem is because of time shortage, I didn't include them. We'll have it some time. But I'm making a bridge between teleoptometry and teleophthalmology, where they are not allowed to treat, but they can actually screen the patient. They can do OCT, they can do retina photograph, and they can have a consultation with an ophthalmologist, maybe institute or individual doctors. And then finally, make sure that the patient near that optometry clinic in a remote place, maybe a Devaria in Uttar Pradesh near Nepal, can have a ophthalmologist they can go next door, so they don't have to travel. So I think I also reflect, Dr. Sandeep Palla will be talking about it. The Echo India was started as an Echo project in the United States by Dr. Sanjay Arora, and when you see his video, he mentions that instead of getting the patients from rural America to centers, and I think he's in the UCM University, where in Albuquerque, New Mexico, University of New Mexico. And he says, instead of getting the patient from remote place to the university hospital, he said, we'll bring the technology, we'll bring the patient care through the telemedicine. And I think that is why probably with the first program with the Echo India, it will be very vibrant and probably will touch any person from Kashmir to Kanyakumari and from Kutch to Arunachal Pradesh. With this, I again hand over my thing to Dr. Subudhi, the efficient Secretary General. Usually Secretary Generals are young people, but we have a younger guy, and that is Subudhi. And he's really, I think, a dynamic person more than me. And I'm glad I have a dynamic, we have a dynamic secretary. Thank you.
Thank you very much, Professor Natarajan. Really, it's a pleasure to hear nice words from you. So now I think it's addressed by our IMA President, Professor Dr. Jailal. So before that, I would like to say a few words about him. I would like to share his. Is it visible now?
Yes.
Am I visible? Yeah. Yes. So it's a pleasure to introduce our President, IMA, Master President for this current year 2021, Professor Dr. A. Jailal, a young dynamic professor, I would say. He has degrees already mentioned in his name. I don't want to go into details, but at present, currently, is a professor of surgery at Tirunelveli Medical College, Tirunelveli. So out of his qualifications, two qualifications I would like to mention. One is MBA, Hospital Administration, 2000 Canada. And of course, he has done a PhD surgery at BM University, Salem. And if I go on describing all his positions and everything, it will take more than 1 hour. So I've just mentioned that he has held various posts in IMA, both state and national level, also many international associations too. Member of several organizations and many awards. Out of them, few awards I would like to mention here. Definitely, a Best Doctor Award from the Kanyakumari District Collector and Best Doctor Award from the Government of Tamil Nadu, and Best Teacher Award from TN MGR Medical University, and Best Teacher from the National IMA 2, and Best Rotary Award from Rotary International and IMA, Best State Secretary Award consecutively for 3 years, 2010, 2011, 2012. And of course, in his profession also is doing an excellent job. A Best Surgeon Award for doing maximum surgery for HIV patients in Kanyakumari district, and received Malikan Fellow of Wiseman Club. So he had numerous publications. He has published many chapters in the textbook of family medicine, and he had 30 research articles to his credit. And he was in the editorial board member in 5 international journals. He is blessed with a gynecologist wife, Dr. Shiva Jailal, and 2 sons, and both are again MBBS doctors. So his family is complete of doctors. His motto always he speaks, love your neighbor as you love yourself. And what I am today is the gift of my God, and what I become tomorrow is my gift to God. Few lines I would like to say. I would say that he's a man of action. I have the honor of working with him in the IMA Standing Committee for the Prevention of Diabetic Blindness. So I am the secretary of this project. And the day one, when we had meeting, he said, show me action. You must do this much 1 million diabetic retinopathy screening. So he's a man of action. Every time when he meets us, always tells how much you have proceeded, how much you have done. So with these few words, I welcome you, sir, to this August gathering of Teleton Society first symposium. Please give your dynamic, high-sounding words to stimulate us to move forward. Thank you, sir. Welcome you. I welcome you, Professor Jayal.
Welcome,
Thank
Dr.
you very much.
Dr. Jailal. Welcome to our. I hope you will continue till the 7:30 in the evening, and we want to be vibrant with the All India Ophthalmic Society, Tele Ophthalmic Society, and IMA, so that I think we can move. And with Telemedicine Society, I think we can shake the country, and I think the country needs all of us. And I think with the entire world writing to me on that this is a problem and feeling bad, I think we should say the doctors are doing a great job. Forget the administration. So with you, thanks to you, sir.
Thank you.
And
Thank you very much.
You are from the southern sharp part of India, from where Dr. Kim and myself hail from.
Thank you very much, Professor Dr. Natarajan sir, Professor Subhuti, and Dr. Ganesh Joji, and all other dignified leaders of the Telemedicine Association. I'm extremely delighted to be with you. And we are in a pandemic crisis, and we are in a search of finding solution to stop this pandemic or get over this pandemic or mitigate this pandemic. And there are various means and ways which we need to understand this, but one of the option in front of us is using the telemedicine concept to the maximum possible level, so that we will be able to reach out to the even unreachable people, and also we are able to protect our medical fraternity. I am very much shocked and pained to report to you at this moment, in the last 25 days, 92 of our doctors have died. This is unbelievable, but it is true. And our own doctors who need to be in the front line, who are exposed to the people to the maximum possible level. The viral load with which they are exposed is too much, and that is resulting in a great havoc in our medical fraternity. And this is a one reason enough for us to make our people to realize the need and opportunity by which the telemedicine can help them and prevent them from getting exposed unnecessarily to this pandemic in a maximum possible way. So though even it is not for the social cause, at least for my selfish interest for my own doctors community, I am very much particular. We need to promote this telemedicine to the maximum possible level. The most important obstacle or the most valuable obstacles, whatever we are facing in telemedicine, is only the mindset of our doctors. We always feel it is not for me. It is for somebody who is in the city, somebody who is more much degrees, and somebody who is in working in a corporate hospital. And that mindset we need to dispel, and that is everyone, irrespective of the where he is practicing, whether it is a rural area or an urban area, and we need this telemedicine concept to be prevail and percolate into the day-to-day practice of our individual. And by doing this telemedicine, and many of us, many of our doctors feel, and they will lose the patient, but in fact, it is taking away the geographical burden, and you are only going to enhance your patients and enhance the load of the patient. And your time is going to become a precious, and you will be able to serve at your convenient time to the people who are in the need. So there are a lot of ifs and buts in that telemedicine, but still we will be able to promote this at an opportunity level and to make this possible for the people to get adopted. I am confident, and amidst pandemic crisis, a few good things has happened, and one thing is on the pandemic. I mean, this telemedicine, which now many of our doctors and including the surgeons has adopted to the telemedicine, and maximum possible level it is being used. The two terms which we always use is the e-health and m-health, which is the mobile health. And now the mobile health is going beyond the level, because the m-health is now available to everyone's at their pocket. Now the doctor is at your pocket, is the team which everyone is talking about that. When you are going to any Western country, it is quite difficult to find a face-to-face consultation with many of the consultants. But all the people are very confident, which they say that their doctor is at their pocket and their time of need, and they will be able to get into their doctor's role. That is absolutely true also. It is true for the, not, it is coming to true in India, but all the Western countries, it was even when we meet some of the doctors, 10 years back, 15 years back, they were very happily sitting here in Chennai, but the doctor used to say, I am very confident I am sitting here because all my patients' record is in my pocket. And anytime they get into any problem, then they will be able to communicate. I need not to go back to my own office. I can get this done through my own computer and talk to them in a more appropriate way. So to that level, and that importance of telemedicine has to be taken to the mindset of every individual of this doctors community. I'm so happy that Telemedicine Association, that you are taking an yeoman serve, and you are taking a lot of good work to see to that it is being propagated to the people, especially in the field of ophthalmology. There was a lot of things on the retinal screen to the identifying the early prematurity and the blindness, and everything is being done by the M-health or the E-health, which is the option we are having to that. But see, having said that, but it is also our responsibility to ensure the hiccups in the telemedicine has to be overcome, and we are able to give some remedial solution for that. And everyone now fear, the most important fear which is there in the minds of the people is the autonomy and the safety of the data which has been shared through the telemedicine concept. Unfortunately, we do not have a rule or the set of action and the guidelines and the protocol which is there, which guide and overrule and everything which is there in black and white in the telemedicine. Even in Western countries, they are finding it difficult. It has an other side of that. When you are putting too much of rule, the innovation and the new things will not be able to come into that. So with that dilemma, that many times we are not able to have enforced a systematic planned and systematic organized rule structure. There are few attempts are made, but still we are in a lot of miles and miles to go to see to that, and we are able to regularize this in a common platform. And if at all one new invention is coming, it will be only on telemedicine. Everyone just he finishes his BE and he comes out and I have a telemedicine platform, please come and join. And every doctor is coming, getting, and there's so many advertisements and so many calls from various telemedicine people saying that my platform is good and your platform is good, and that has an advantage. That just like that, we are used to up to share which antibiotic is good, and every company is going to come and say the goodness of this. And this is coming in propagating in millions. Now the projects are coming up. The Make in India concept with the new startups programs are coming, startup telemedicine concepts are coming. So my appeal to Dr. Professor Natarajan and other colleagues here to ensure that strict guidelines or the platform at which and how the telemedicine platform to be there and who is going to own that, and how we are going to systemize the safety of the data, whatever we are doing, how we are going to ensure the data which we are safe, sharing it. And many times the black marketing of the drugs, not only the drugs, Now today, one of the most valuable thing in the world is data. And when you have a data and you are the powerful man, previously we say knowledge is power. Now I believe that data is power. That every company and everyone is interested in data. And if you can show that a study which says that how much this drug is going to have an effect to you, what is the mindset of the people, and if the data you can share, and that is becoming a big business across the country. So that is also an option, a fear in the minds of the people, and how this is going to help in that, and how it is going to be a part of solving that issue instead of solving the issue, whether it is going to land up in another difficult area, another area where we are going to have in a problematic area. So our association, our leaders has to sit together and talk with the government and finalize that what are the minimum requirements of the safety criteria, what is the encryption which they are going to make, and where it is going to be the goodness to store in iCloud, or it is a designated, dedicated server for which that is going to be a useful one. And that intricacy of this has to be talked to the people in a very, very possible way. The third thing, it is whether it is going to give the overconfidence on the minds of the people instead of adopting to the basic steps or basic that confidence level, whether the telemedicine is going to give an anxiety and unnecessary mental stress to the people. There is I recently read a paper which says that those who are very actively doing and dedicated to the telemedicine, they are using that lot of wearable devices, what we are having, artificial intelligence and wearable devices, and they are in a lot of mental stress. And we previously used to say, you have a diabetic, you come and check once in a month or once in a week, and you are you go ahead and get well. And most of the people were happy. They will only worry about the diabetic blood sugar when they come back to us. And now every day, now they are getting worried. They are in a dilemma. They are just reading that figures and reading the values. And I think the good teachers like Professor Dr. S. Nadarajan sir will always, we used to say it is, we are not there to read and treat the case sheets or treat the data. We are going to treat the patient. And unfortunately, there is a small shift is taking place. Now we are going to treat the data and not the patient. So that dichotomy also we need to put a lot of mind into that, and we need to bring that human face or humanity face into that. And there are various works are going on in the artificial intelligence system and artificial the process, how the intelligence of the humanity can be brought in. There is a difference between artificial intelligence and how we are going to use that. Artificial intelligence is good, but that is only becoming valuable how we are going to intelligently use them for the purpose of the goodness of the patient. So that area also we need to come out and openly support the people. Yes, the days are very going to be really a good future is there for telemedicine. More and more people are coming in, and how we are going to do the hand holding with them and guide them appropriately and lead them to the path in which they will be used it judiciously and rationally, and make a most efficient use of those systems which is available is in the hands of all of us today who are talking about this telemedicine concept. As a leaders, as a pioneers, as the people who want to show the pathway to the youngsters who are coming out, and we need to bring out very solid ideas and solid documented values system in which with which our telemedicine can go ahead. And I'm so happy and so confident, and all of you will be working on that. Today I just gone through the topics which we are going to discuss, including one good topic I was hearing, break the chain using telemedicine. I think that is our dream. And if that is happening, that we'll be also happy that we will not be needing the lockdowns also. So wishing you all the best on this moment, and looking forward with a great hope and expectation. This conference, this workshop will be able to bring out some solid guidance and solid hand holding for us to go forward. And I assure on behalf of Indian Medical Association, all the possible helps, whatever you need for us to be with you and partake with you, and in the process of propagating this telemedicine to be utilized and used by many of our medical fraternity in the country. Thank you very much for this opportunity, and looking forward to hear from you all.
Thank you, Professor Jailal, for your dynamic speech. So really, I thank for your concern for our medical fraternity. Second thing I would like to say that because the telemedicine is going to become very fast, we have come with the Tele-Ophthalmology Society of India. Now it's a separate branch to look into that basically blindness in a society, and we want to make it a diabetic-free country in the 2025. That is our aim, and we have a dynamic president, Professor Natarajan. So we need your help always, because AIOS, IMA, and TOSI can jointly make India free of diabetic blindness in 2025. Thank you very much for coming. Now I think we should go for the SIT program. We'll start. I will hand over the mic to Dr. Sheila and Dr. Rajiv Dhamman to start the SIT program. So it is over to you, sir. Dr. Rajiv and Dr.
Thank
Sheila.
you. Thank you, Professor Subudhi. We will start with the scientific. Welcome all of you, and I'm sure you had a good start of this meeting. Next a couple of next 1.5 hours, we'll be dwelling on various aspects of telemedicine and teleophthalmology. To start the ball rolling, we'll have the first speaker, Dr. Shashi Bhushan Gogia. I was going through his details, and probably one of the few people who have such an in-depth knowledge on telemedicine and telehealth. He has written a book on fundamentals of telehealth and telemedicine. He's also president of Sathi and has various other positions. Welcome, sir. I invite you to give your talk on implementing telehealth in day-to-day practice, rationale, processes, and challenges. Dr. Gogia, please.
I request
Thank you,
all-
thank you, Dr. Rajiv. Thank you, Dr. Sheila, for inviting me. Sorry, Dr. And I definitely congratulate Dr. Natarajan and Dr. Subudhi for picking up this opportunity and making a new this thing. Interestingly, we've been working on this for a long time. We have one of the major projects which Sathi has done is on teleophthalmology in Mizoram. Anyway, I don't want to waste time because we are running short. So I'll just share the screen and let's hope I'm making sense to you people for this thing. So as my topic is already introduced, so I'll just start from here only. Basically, we'll be talking about we'll be talking about giving an overview, give a brief of what telemedicine and telehealth concern, and then we'll end with the summary. An important thing which I want to talk about in implementation is what is known as change management, which is changing from a physical care world to a telecare world. This is a very important one. One of the things which have caused many projects have failed. So I'll just introduce that telemedicine and telehealth are interconvertible terms for some. Telehealth is the provision of healthcare remotely by means of a variety of telecommunication tools, which includes telephone, smartphone, mobile with or without a video connection. But the main thing is it is about transmitting rather than moving. So what transmission that takes place in a jiffy, in nanoseconds. When you have to move people, it takes time, it costs money. So all these things are cut down with the thing. But actually, it is much more than that, and this is what I will try to explain, because this is what it started with. It encompasses health provision as well as education, and the term, because of the expansion, has expanded to digital health, because now we are adding processing. Tele is the communication part, and medicine and health are as what you know. But when we added processing of information and knowledge, which has already been discussed, then we moved on to a different world altogether with AI and all that. But I don't have time for all that. So I'll just go through these three basic definitions. Telemedicine consists of teleconsultation, which could be direct, primary care, secondary care, tertiary care, etc. In telehealth, the information processes are adding. So we are adding teleeducation, wellness, and public health with ancillary components. And also we do what is called analytics and knowledge management. And when we do all sorts of things, CDSs, computers, digital support systems, blockchain, robotics, then it becomes part of AI. No time for this again. So the basic case for telemedicine is where there is immobility either of the patient or the provider, when there's emergency because of time and or disasters, and of course these days because of social distances. Because the core thing is when the provider and the need for support are not in the same physical location. And in the COVID period, we anyway don't want them in the same location. So that's why it has become, unfortunately to say, a godsend. The COVID period has become a godsend for telemedicine promotion. It's a wrong thing, but we are benefiting. Let us accept the facts. And so when there is a person in a remote location and he does not have adequate skills, health skills available with the local people or knowledge within the local provider or even equipment, we can do telemedicine, but the equipment sometimes can also be sent. Sometimes you have to make do without the equipment, but better that you send across the equipment and then you can do a better teleconsult and telesupport system. So what improves as a result is the patient satisfaction with better clinical workflows. You can work from your convenience, even from home, continue family and diminish chance of COVID-19. It is definitely less than ideal, but it will be a fallback option for those who are dependent on those without means of travel, when time is absence, for teletriage. It all depends on the device and connectivity. For chronic diseases, you can use medicine refills and do locally possibly procedures like stitch removal, very simple thing, and dressings and all that. Even that sometimes need a transfer. We can do that at least through telemedicine. So make sure whatever place you are providing the care for is suitably possible to do it. Only the diagnosis as element and where specialist support is actually in healthcare is very small amount. So the nursing, we do need a better nurse to doctor ratio. Nurses can be anywhere, health workers can be anywhere, they can do that. The best way to do it is that you have to have a continuous previous health record. And this is what Dr. Jailan said, and thank him for talking about that. So let's just take a simple case scenario. You have a local village practitioner, patient requires a dressing. This will be low cost, 20-30 rupees, but he has to have the knowledge, the drugs and equipment. But if not, he can go to the doctor, it's still affordable, 100 to 150 or so. But when he needs to go to a specialized center, which upper classes sometimes do, then this costs a short up to 2,000 rupees because of the cost of travel, high cost treatment, which is less so, but the cost of stay and relatives and time of work. This nobody considers, this is not even considered a health cost. And so doctors are not all that bothered. They should, because patient finally is spending on that much. So this is the classical issue of telemedicine. There are three main types. One is called store and forward, in which the information travels asynchronously through SMS, WhatsApp. So somebody writes it, it is read at a different time. That's the asynchronous part. Or somebody puts a data in the health and electronic health record, it is seen later, or maybe even at the same time. But synchronous means they are point to point, second to second contact between the two partners. It is best is telephone, video consultation also. The best systems are what are called hybrid, which contain both of the above, because synchronous means a lot of other synchronous is also required of the doctor with the time. He may be in the bathroom, he may be on leave, he may be doing something else, he may be seeing another patient. But health apps, we should do most of the work asynchronously because the most expensive component in a consultation is actually the doctor's time, and we have to think of saving it to make it a success. Then, of course, the third type is what is called telemonitoring, in which one side is the device only, not the person himself. This is how the information travels and how they happen. So you have a home healthcare through devices IoT. A person stays at home, he's provided care from a doctor. Most of the common things which are being promoted, this is a patient to doctor. To my mind, and this is done through web opinion, WhatsApp or whatever, to my mind, the most important is what is done from a health worker to a junior or a junior doctor to the specialist. And you can be friendly calls within hospital, apps, projects, because this is where you can do the maximum support. Of course, in telehealth, patient to doctor is, a COVID period, patient doctor is most, but even for other places, like for an ophthalmologist, if there's a person in a remote area, he knows how to, at least we can send the photographs across and give an appointment to the patient that when does he need to come for surgery. In our own project in Mizoram, we showed that a person needs to come to the hospital on an average for 5 times for a cataract. Sometimes the doctor is not there, sometimes the cataract is not ready. With that, we could reduce it through these trained people to 1 to 1.5 visits only. Other, of course, are between doctors, satellite centers. So, I don't want to spend time on this. So this is how it actually happens. When you are sending the data across, you break basically the health record has to travel. What are the components to make a diagnosis? So the normal components, history, examination, investigation, etc. And this is broken down to digital components, text, sound, and all that. And some of them are low bandwidth, some are high bandwidth. So for investigation, low is high bandwidth. You can send images, you can send sound clips, then you can send a video conference to correlate But that should be the minimum possible, because not only is it high bandwidth, it means there's a committed time required of the doctor. Otherwise, store and forward can be done in the middle of the night. A person can wake up, finish the job, and go back. When he's in his car, he can do it. But video conference is unfortunately thought to be the best form of telemedicine. It's the most easiest to do, but implementing for a long time has got a lot of problems because of connectivity and other issues. So just remember, the treatment hinges on a diagnosis, but information flows is the rest on a reverse pyramid, which is very, very important. First, you have to identify which patient are we talking about. Take a history and examination. This is 80% of the diagnosis. Then you add images, sounds, multimedia. The actual above part is only 10 to 20% of the diagnosis. So this reverses the main thing is that if you are talking to the wrong patient, you have the wrong patient ID that you're doing it, your entire thing is lost for a 6. You may make a lot of mistakes. A person may send the wrong X-ray. You may be talking to the wrong patient. So these things, through the history, you should be able to correlate. If a patient has got a problem in the chest and an X-ray of the foot is sent with a fracture, you will be talking about the fracture all the time. So you have to understand that miscommunications do occur, and this is where telemedicine has gone wrong. You have to follow a certain path to make sure it is done well, and try with the simplest first. These are the communication words. They vary. You have got, speed, depends on very slow speed. Text requires very slow speed. But the recording and search of that is the easiest. Well, you have either wired transmission or mobile. So you can have dial-up or wireless. But I don't want to spend time more on this. But make sure what is happening. But the important thing here is what I want to tell you. Normal care to telecare is painful. There's a lot of things. People say that I have got the best technology. Technology does not work so well as your motivation and understanding what you're trying to do. You have to understand the workflows. What are you doing? Can it be converted on an IT system? You have to do a gap flow access. But the most important thing is what is called change management. Is you have to do advocacy of the people, train them how to use the systems. Most of the systems just sold in the past, they have failed. A lot of them have failed. ISRO had set up so many centers. There were people were transmitting from this. Why did they fail? Because the people are not wanting. Of course, we know that Dr. Sheila Chand did a great job, but she is one of the few exceptions. She will agree, I hope, although she has done something good, but on the large, these are failed because they have been overtaken by other processes. Here, if we follow a training and a motivational approach, then you can do wonders, and we are doing it already. And always remember, the better way to send this thing is through images, because the diagnosis is what you are depending on. And do it asynchronously, mark out what you want, and you'll get a quicker result. So telemedicine has worked best in those fields where the time or images or video conference works best. That's why wound care, dermatology, ophthalmology is high. In psychiatry is high because video conference. COVID pandemic, it has become essential. Otherwise, it just goes down the list. So this is a patient whom I done wound care. He came to my place. He could go back after a week or so, and kept sending the images from home that the ulcer is healing. So the opportunities, there is better awareness. There is through social distance, it is patient driven. Patients now can do it. There's government support through telemedicine practice guidelines, but prefer to do it through apps and templates. Only then it will be faster. I'm showing you a template of prescription, which took me only a minute to make because everything is through template in my EHR. This is a prescription sort of prescription that I give. So many details that I can send for a COVID patient. Since often as a surgical field, these are the places we should work on. Don't try to provide everything through telemedicine, because then you'll run into problems. You can do pre-op assessment, patient appointments, emails, whatever, follow-up, telemonitoring and medical tourism, telequiz. So all this will help in the surgical field. So just to finish off, start with a mobile, start with a computer with a big screen or a tablet. You must have to understand how to do a video consult. You should be facing the light, allow comfortable sitting, invest in an EHR system, start with whatever you're confident, like a WhatsApp, email, then shift to a dedicated app, invest in the peripherals depending on your need, and you are home. You can start doing it. A lot of people are not doing it and finding a lot of success. This is my last slide, just to show how you can send your photographs across. You can tell your patients when you want to consult someone, put it on a video, on a digital monitor, put a completely white screen, put an X-ray across, click with the camera and send it across. So in summary, for starting your own place, change management is the most important. You have to do capacity building, use appropriate technology. Don't over invest in the technology. You'll be burning a lot of fingers. Keep it simple. Think of the cost and the benefits. Experience the problem and motivate yourself. If you think that you need the social distance, you are anyway motivated to do telemedicine. If you see a patient not able to come to you, although is in dire need of help, you will feel like supporting it. So identify the target, but remember the constraints. Which is best. Don't try to solve all emergencies because you can't start an IV drip remotely. If it requires a procedure, don't try it. If you're not sure of consent, don't try it. If there's incomplete information, don't try it. But you may do it for complex clinical if you understand and the patient understand that you are trying to help. You are following the good Samaritan rule. If without me, nothing could have worked. So something I'm trying to help. Thank you. Hello.
Thank you, sir. Thank you for the nice talk and lot of learning. We'll go to the next speaker. 1 minute. Dr. Sheila, you will be
Thank you,
introduced.
Rajiv. The second speaker is Dr. K. Ganapathy, Director, Apollo Telehealth Services and Apollo Telemedicine Networking Foundation. He was the past president of Telemedicine Society of India and one of the pioneers for telemedicine in India. And he is also the past president of the Neurological Society of India and has many publications to his credit. Now I invite you, sir, to deliver the lecture.
Let me share the screen, please. Can you see my screen?
Yes, sir, we can see your screen.
Yeah, okay. Thank you very much, Dr. Sheila and the organizers for inviting me for this opportunity. Now, in the 720 seconds is too little a time. So I'm going to confine myself to some aspects which are not generally discussed. I was very happy when the president of the IMA mentioned about the possibility of dehumanization, depersonalization. I think this is very, very important. I belong to the BC era, not before COVID, but before computers. I was the last neurosurgeon in India who was trained even before the CT scan came. And over the next couple of minutes, I'll try to show you that even if you're a retinal specialist and an absolute pundit, so far as diagnosing pathology in the retina is concerned, the patient is concerned, you need to get across to the patient virtually. This is the most important thing. So tender loving care can be exhibited virtually, and I'm going to show you how. We are all aware that telemedicine essentially consists of the application of hardware, software, connectivity, acquiring images, storing them, retrieving them, digitally manipulating them, and so on. The most important thing is we need to be future ready. When I started telemedicine 21 years ago, nobody taught me. But today the world is changing so much that I think it's absolutely essential that all of us undergo a formal orientation and training program. Now, I would like to emphasize again and again that this clinical wisdom should be contextual. What is to be done at that time, at that place for that patient by you from where you are, taking the socio-economic picture and specific requirements of the patient and the family. I never treat an MRI image. I never give an opinion on a CT image through teleconsultation. And I implore all of you not to restrict your treatment to the diagnosis of the retinal image, but get across to the patient. That is most important. Always try to find out why the patient did not come to you physically. There must be some reason, and that would definitely be helpful. Again, never ever get overawed by rules and regulations. There have been several judgments which have said that clinical judgment is the most important thing. Technology is only a means to achieve an end and not an end by itself. As a clinician, do your best, act in good faith, having only the patient's interest first and foremost. In the early years of my teleconsultation, when technology was a problem, there have been several occasions when I called off the teleconsultation. There is no ego involved here. I said, look, I am not happy with the quality of the images. I'm not sure, I may miss something. So better you come over personally with the images. Now, these things are unlikely to happen now, but if it does, please do it. Just to give you an example, I'm an old-fashioned doctor, and perhaps I would like to do a rectal examination to find out the size of the prostate. My student is more comfortable with the 4D pelvic ultrasound. So for him, teleconsultation is fine. For me, it is not fine. So this is what I mean. The context, and the context alone is the single most important thing. The same standard as used in a face-to-face examination. Last lecture, the inventor of the gamma knife said a half a century ago, a fool with a tool is still a fool. And I think that is very important. Professional judgment alone matters. Now, those of us who intend to use telemedicine as a major component, we need to understand and streamline the entire workflow, starting with appointment scheduling, management of the staff, reduce patient wait time. Just as you do in a face-to-face encounter, patient wait time also should be reduced in a virtual encounter. The workspace design must be convenient and should enhance the interaction. Most doctors giving teleconsultation are not aware that body language is very critical. The way you dress, treat the patient with importance. I mean, personally, there may be nothing wrong if you are wearing a pajama or a banyan and giving an opinion. The opinion is the same, but still it is necessary that some amount of formality may be there. The patient experience is critical. He must go back with the impression, wow, that was a fantastic consultation. It was even better than a face-to-face consultation. So this is what is required. How many of us are aware or pay any importance to the room in which the teleconsultation is given? There are a lot of things here. The distance from the floor, the distance from the wall, the dress you wear, the lighting of the room. Daylight is not enough, even if it is at 12 o'clock in the afternoon. You must have artificial natural light. 2,800. There are a lot of technical details here. There is no time to go through all this. But please be conscious and take a teleconsultation exactly as you would do. After all of us spend a lot of effort, time, and money in building our consulting room. This should be the same thing so far as a teleconsultation is given. The color of the wall, the type, whether it is shiny, glossy, backdrop, everyone is important. I'll quickly go through a few clinical images just to tell you that whether it is the retina or whatever part of the body it is, the clinical continues to be the most important. We have done about 35,000 teleconsultations in dermatology over the last 2 decades, and I'm not aware of a single instance where a mistake was made. On several occasions, our dermatologist, of course, had to call the patient because he wanted a biopsy, but whatever it is, a correct differential diagnosis has been made, provided the history is there. The history is very, very important. Now, just to show the importance of telemedicine, we run telemedicine centers at 14,500 feet height in the Himalayas. Our dermatologist diagnosed tinea capitis in a single child who was brought to the telemedicine room. But being an experienced person, he said this usually comes in monasteries. So he persuaded, he asked us, and we told our staff, we were proactive, we went to the monasteries, and just as we predicted, as the dermatologist predicted, we picked up about 25 children in the monasteries, all of whom had tinea capitis. Just an example of somebody whom we initiated thrombolysis from Apollo Main Hospital, Chennai, 2,800 miles away, external temperature minus 25 degrees centigrade, December, Saturday evening, chest pain. My emergency doctor said, even though the ECG is normal, I don't like the look of this guy. He just doesn't look all right. And he told our nurse that don't send him back. Repeat the ECG after 45 minutes. And as clinically predicted, we were able to demonstrate an ST elevation, and we initiated thrombolysis from Madras to a patient in the Himalayas. Yet another example of supraventricular tachycardia. This was even more dramatic. 220 was the pulse rate, And it so happened that the person trained in the use of a defibrillator was on leave that day. We had a young local girl who was only talking Himachalese, as they call it, not even Hindi. But our doctors in the emergency ward, a very well-equipped emergency ward in Chennai, using a mannequin, he demonstrated to this young 20-year-old girl what is a defibrillator, showed her how to put the paddles, what is it, and through an ordinary webcam, handheld her, telementored her, and made her do the very first defibrillation in her life. The patient became absolutely normal and was discharged. I think in 2021, it's a crime to make children like this come back for a follow-up. Pediatric cardiac surgery obviously can be done only in tertiary and quaternary care institutions, but follow-up can be done through telemedicine. Again, another example, acute abdomen. All that it is required was a doctor to say is a bladder is distended, a catheter was put, and lo and behold, the acute abdomen totally disappeared. Tele-emergencies, a very bad wound, again in the Himalayas, we were able to tell the local MBBS doctor there who had never sutured a complex wound like this, what is to be done. And a few days later, you can see the patient doing much better. Personally, I have given more than 3,000 teleconsultations in the last 2 decades. 2 minutes it takes me to do a detailed examination, except the fundus examination. Of course, I'm able to do a cranial nerve examination, ask the patient to look to the left, to look to the right, and so on. This is a patient in Africa, a bead of pus outside in the scalp tells me that there's a possibility of osteomyelitis, intracerebral abscess, etc. And I advise the bone flap to be removed. A detailed neurological examination through an ordinary mobile phone. This is a patient, and this is all that I want before I can actually give a prescription. Obviously, this little boy has got mental retardation. All I had to do was to spend 10 minutes with the mother and tell the mother there is no point in bringing the child to a tertiary care hospital. The detailed evaluation of a radial nerve injury, I'm able to examine the individual muscles, do a detailed sensory examination, and so on. A meningomyelocele diagnosed within 45 minutes of the child being born at Andaman and Nicobar Islands. It takes me, an experienced neurosurgeon, a minute to make a confident diagnosis of future management of this patient. Now, here again is an example of a person who the family, I was very surprised when the family said, I refuse to advise the patient without seeing the patient. And then the patient said, sir, with a mobile phone, I will show you the family. Is this okay? So yet another instance, this was a patient from Dubai, and I refused to make a prescribed anticonvulsants, though the history very strongly suggested a temporal lobe seizure. I insisted that they capture it on a video, on a mobile phone, and they sent me this video. Unfortunately, the video is not playing here right now. And similarly, another patient a few months ago during the pandemic, again in the Himachal Pradesh, examined at home. I could go on and on like this. This is just a demonstration of how, when you give a teleconsultation, it is essential that your qualifications, your registration number, you can see Tamil Nadu Medical Council registration number, permission obtained from so-and-so to record video. And you can see on my letterhead, the prescription, I put the generic name, carbamazepine, 100 milligrams at 8 a.m., 200 milligrams at 8 p.m., and so on. Fundus not examined, telephonic review, etc. All this sent by email. So you could go on and on, but then I need to confine myself to the time. So I would like to conclude that it is not technology which is important. In 2021, technology is becoming available. What, in my opinion, is required if telemedicine is to really take off? It is not enough if there are a few thousand doctors. 20 years ago, there were a handful of doctors. Today, perhaps there are a few thousand doctors passionate about telemedicine, but that is not enough. The patient should demand a virtual consultation. And when will he do this? He will do this only when he gets a tremendous experience. When those treating you don't introduce themselves or make eye contact or say what they are doing and why. When these simple things are addressed, it makes all the difference. So once again, my take-home message would be, it is not the technology, it is not the process, it is you and you alone who can produce a customer delight by the way in which you interact in those few minutes. How many of us today, with all the technology available at our resources, listen to a patient? Sir William Osler 150 years ago said, listen, listen, listen. He is telling you the diagnosis. And this is what I think is the single most important thing. Not technology, not EMR, not hospital information system, not complying with the telemedicine practice guidelines, but sympathize, empathize, give tender loving care virtually, wipe the tear off the patient. For the patient, what you are telling him are pearls of wisdom. And please remember to communicate this. This can be done virtually. Thank you, the organizers, once again, for giving me this opportunity.
Thank you, sir.
Wonderful talk. Before Rajiv, I'm just interrupting for 30 seconds. The idea is, I think Dr. Abdul Kalam gifted a book called Man and Medicine it's a compassion medicine by the first Dalai Lama Rinpoche and also Dr. Schlim. I think it mentions about how a doctor has to be compassionate. And I'm writing a book, Compassionate Eye Care. I think you summed it up by saying, we need technology, sir, but at the same time, everybody should use compassionate eye care. You need electronic media, everything, because we are going to treat lakhs of patients through this and not hundreds of patients. So I think with this, I give it to Rajiv.
Thank you, sir. Thank you, sir. We'll move to the next speaker. We have Dr. Ganesh Arun Joshi. He's assistant professor in CRC Bhopal, and he has an experience, or his interests are mainly in pediatric and neurological rehabilitation, assistive technology, and advocacy for persons with disability. I would invite Dr. Ganesh. He would be telling to us something on medicine for inclusive and accessible healthcare. Dr. Ganesh, please.
Good evening, all of you. I think some screen share is on. That's why I'm not able to share my screen.
I think
now it's okay. Good evening, all. Thank you so much, Tosi, for inviting me over here. And it has been rather a change of life since I met Dr. Gogia in 2008, when this telemedicine things were in the boiling phase. And I have been developing and finding out various niche areas where telemedicine can be helpful for all of us. That's why my topic over here today is telemedicine for inclusive and accessible healthcare. As we all know, that levels of healthcare are divided into three parts: prevention, cure, and rehabilitation. This all we have learned in our PSM, community medicine. And as we are called doctors, doctors means teaching the proper way of healthy living. So our main task is prevention. That is, before any disease gets initiated, how a person should have a good lifestyle, and there we should be able to prevent any kind of diseases coming in. But unfortunately, we are all taught how to cure a disease. Means after the disease occurs, how to cure. And that spectrum of cure, although there are so many specialties, super specialties, there are esteemed doctors in our modern medicine, but this spectrum of cure is very short. And every patient, every person, he looks out for cure and cure only. Even if it is mental retardation, even if it is autism, even if it is even amputation of the limb. A patient going for amputation, he will always ask this doctor, well, doctor, how can you save my limb? Please try, please do that. And I have seen such a patient who has undergone 12, 13 serial severe operations to save her limb. But unfortunately for her, It was amputated and removed. And fortunately for her, again, later on, after amputation, she was fitted with an artificial limb, and then she was so happy that her pain is gone and her life is on. So, this is where rehabilitation has its role. That's my specialty, physical medicine and rehabilitation. I've done from AIMS in year 2000. And what rehabilitation does is, after curbing the disease process, the rehabilitation specialty trains the person how to settle back into his life with the best possible potential that the person has. In disability and rehabilitation, I would like to introduce the topic here. We all are very well aware that disability is a part of everyone's life. We there is so there are so many diseases, disorders that make a person temporarily or permanently disabled. Even I myself have suffered a backache for about 2-3 weeks, and for that backache, I was not able to stand or walk inside the house itself. But since I am in this field, I got a wheelchair. I tried to move the wheelchair in my house, which is built up in a barrier-free fashion, and I was just trying to that yes, the house is accessible and wheelchair is helping me out. So this is how temporary and permanent disabilities make a big toll, and that is how 1 in 7 persons in the world have some kind of disability that needs some kind of rehabilitation. So rehabilitation medicine is not a thing that is restricted to the 2% of population that our census says, that only 2% are persons with disabilities. Actually, those persons are having very severe disabilities and they have to live their life with disability. But in addition to that, there are so many people who are having different diseases and they do need rehabilitation. That's how PMR, the rehabilitation field, looks into overarching disabilities from all kinds of specialization, starting from our ophthalmology, ENT, uh, uh, cardiology, neurology, orthopedics. Although our main intention is to touch orthopedics and neurology. So, excluding acute and remitting conditions, the WHO says that 3/4 of the years lived with disability do need rehabilitation. And in low income countries, manpower is very, very low. As you might have seen, the people having diploma or MD in physical medicine and rehabilitation, the numbers is very low. That is our IAPMR association. Hello, am I audible, sir?
Yes, sir, you're audible.
Sorry, there was a phone call in between. In high income countries where PMR and the rehab paramedics, they are more in number, still their transportation, access barriers, all those things limit the rehab services. So, in while talking about persons with disabilities, those defined as persons with disabilities by the Act, our 2016 latest Act, those people are at least 2% in our population, but actually they may be many, many more. So what United Nations has done, it called a convention, a meeting of the parents and meeting of the persons with disabilities. Then they met together, they propounded their own rights as a human being. What rights are what rights must be conserved, and those were enlisted, and how they will achieve the rights. So this United Nations Convention of Rights of Persons with Disabilities Rights of Persons with Disabilities Act that was passed in 2016. In that, there are 102 paragraphs, and it mandates healthcare in its para 25, rehabilitation in paragraph 27, and accessibility in 6 paras 40 to 46. And the persons with disabilities are named as Divyangjan in Hindi. So, in Sustainable Development Goals of United Nations that we have to achieve by 2030, there are various 17 goals, out of which 3 are mainly targeted to inclusion. That is good health and well-being of all people. And number 10 is reduced inequalities. Means there should not be any inequality between caste, creed, culture, color of the people, as well as the gender and disability. I would like to bring to your kind notice that the disability itself makes the maximum Dalit Varg of all over the world. The most downtrodden people are people with disabilities, and they need a upper hand. So now we talk of inclusivity and accessibility. The words are very clear in their intonation. Inclusivity means a society which is inclusive for all people, irrespective of their gender, caste, color, creed, and all human beings are same. That's what it says. So even if a person is blind, a person is deaf, he should have the same access to our knowledge base, our education system, our earning system, as well as our healthcare. So the social norms, equal opportunities, gender, disability, and even socioeconomic status, the economic status, they should not hinder anybody's access to the full-fledged utilization of society. And this is where we need to ensure accessibility. Accessibility means a person should be able to access transport means, as well as the built-up environment means his house, as well as public buildings and various places of worship, etc. And also information and communication means the way we are talking here, the way we are presenting, uh, we are presenting our slides, but it will be useful for a person having good vision. If there is no vision, how the slides will be presented, that thing we need to take care. Similarly, in the website also, we need to have the W3C uh, uh, consortium guidelines we need to follow, WCAG, and with that guidelines, if we prepare our websites, will be accessible. The website will be accessible to all people, may it be blind or deaf or even intellectually disabled. Now coming to the healthcare protocol. Whatever we have learned from our MBBS through our post-graduation to super specialization, the baseline, as Dr. Gogia said, is 80% is done by history and examination. For eliciting history, I have learned my history during my MBBS in Nagpur. Being a Marathi, it was very easy for me to speak in Marathi with my patients, and for us, it was very easy to deal with. but we had friends from uh, Tamil Nadu, we had friends from Punjab. All those friends had to learn Marathi so that they can elicit very good history. Otherwise, they had a big fear of failing in the examination. So language is a very important accessibility medium. And just like that, if we would have come to Chennai for our post-graduation, we would have to learn the language, Tamil language over there. In the same manner, if a deaf person comes to us, a person who does not know our language, he knows only sign language, then how to deal with that? So we must have a sign language interpreter. We must have very minimal interaction with the use of sign language, or else we can use the sign language from the person's family member. Audio cues also must be provided for the blind people, picture communication for the intellectually disabled, then alternative augmentative communication aids, and electronic medical records and directive home approach. These all will help us very well to elicit history. And this is where I think telemedicine helps us to elicit history at home and talk to his family members, friends, caregivers, and elicit the history in a better manner in his own language. I'm getting message that our chief guest has arrived. So shall I stop in between?
You finish your talk, then after that, sir will wait.
Okay,
We welcome
I finished my talk. Okay.
Ganesh, you complete
Yeah.
your talk. We
Yes.
request Dr. Sunil Shroff to talk after
Yes.
you, after Mr. Bowen.
Yes. Yeah. Coming to the next stage, examination. Now, access to examination room. I have seen orthopedicians who have their clinics and examination room on the third floor, and there is no lift. So how will a fracture leg patient go there? Access to examination table and setup. How do we ensure that? Instruction for positioning, signs, pictures, loudness we need to adjust accordingly, family members' help we need to take. All this is done more easy in a better manner through telemedicine. So there are ways of examination that we can do in a remote manner through telemedicine. And tele-examination instruments come handy over here, and record keeping and retrieval for examination findings also comes useful. So that is why I'm very much excited to use telemedicine modalities for examination too. Coming to investigations, we all, being doctors, are very well aware with the tools. Like if there is a blood sample to be taken, I know that I will be pricked. If there is a urine sample to be taken, I know that I will not have a pain. But if I have to undergo a CT scan, there is a big machine. Uh, I know I have to overcome my claustrophobia, but the machine will not create any trouble for me. It will neither pick me. But all these things need to be informed to the patient. If the patient is a child or intellectually disabled person, deaf or blind, we need to ensure this. That's what Dr. Ganpati was saying, that you need to listen and you need to communicate. So it will be easily possible, much better possible through various assistive technology and telemedicine tools. So cooperation for investigation also will get in a better manner in that way. Then reporting in accessible format is essential. Like if investigation is done, we need to report it in audio format as well as visible reports that are very easily visible to the person. Like elderly people have very low acuity, so the report must be written in very big, bold, and uh, uh, contrast colors. Communicating in interpretation of report also is essential in the person's own language. Modification of equipment for accessibility is required. For example, we need to do treadmill test, and if the person doesn't have lower limbs, how will do it? Then we'll have to modify the instrument. We'll have to give stress through upper limb training, and then the mets and the uh, things, the targets will be quite different. Reassurance in presence of family member is very much better done, and that's how telemedicine link will be much useful. The treatment plan is the main hub that doctor has to ensure. This is where the content, duration, communication, how the treatment will proceed, the ensuring the compliance from the patient, that's most important. This all will be easily possible if we have very regular touch with the patient, even when the patient is at home. And that's why telemedicine will be very helpful. And one thing that we doctors forget is finances of the patient. Whether the treatment plan is financially suitable for our patient, where the patient shall go, whether to government facility or some helping trust or some donors. So all that things should be at hand so that the patient gets the best treatment. Counseling, again, language is the major issue. Sign language, braille instructions, audio instructions, simple wording shall be done. And family member and caregiver counseling is possible through telemedicine in a better fashion. Because in a single visit, where a doctor gives 5 minutes to 10 minutes to the patient, that time is insufficient where you are uh, teaching the patient how to live life in a better manner with his disease. In drug therapy, the name of drug, strength, duration, effects, side effects, reporting, follow-up, all that thing is to be done in a proper manner. Surgical management also, counseling, preoperative instructions, PSC, postoperative instructions, and post-discharge follow-up. That's most important. That is done at home, which is where if telemedicine link is available, the patient will feel much more comforted, will be very comfortable. And that is how the telemedicine is very helpful even in post-surgery cases. Paramedical services like physiotherapy, occupational therapy, therapeutic dietitian, uh, then our various aids and appliances like spectacles, ophthalmic telescope, and various other things like artificial limbs and crutches, calipers. All these things can be very well adjusted if the patient has a video link using those devices at home, and what troubles he is having, we can report to the patient, to the treating doctor. So that's how telemedicine is so intricately involved with psychological support, nursing care, and caregiver at home, so that the person can get the best health care in the cheapest manner. So follow-up at home includes communication, timely reminders that can be through SMS or phone call. Regular checkups can be done through telemedicine, and instruction to caregiver. Nowadays, there is a group of professionals who are getting trained to become caregiver. They can be considered as the helpers to the nurses, the technicians to the nursing staff. There is a 6 months course in caregiving where they are taught how to feed a, a different kind of patient, like a patient with uh, mental retardation or patient with uh, various kinds of disabilities, or even elderly people. So, thanking you. Closing here, I would like to show the slide of Sikkim. This is where I had gone, and I was missing telemedicine because even the telephonic communication was very poor. So we need to deal with such issues, how to manage, how to overcome the issues of telemedicine, issues of hindrances that restrict our telemedicine approach, and would like to work more into that. So main message is that we need to think about our 2% disabled people, need to look into 15% of different kind of temporary and permanent disabilities, including our elderly population, the children who are afraid of coming to our clinic. And in this way, inclusiveness and accessibility is much more easy and acceptable through telemedicine. That's the goodness of telemedicine. Thank you.
Thank you, Dr. Ganesh Joshi. And I take the opportunity from Dr. Subudhi, Dr. Sheila, and Dr. Rajiv to welcome our my friend and guest, Mr. Mohan Irani. Mr. Mohan, you can come on this. I think.
Hello, doctor. How are you?
So everybody asked me to introduce you.
Yes, please. All these very busy people may not be cine goers. So
no, but everybody knows you, and I'm giving you a virtual hug, the Jadu Ka Jappi, and everybody
to all of you.
The Munava MBBS. I think we made the doctors. How a few doctors mentioned about, in spite of technology, telephone, and all the technology, we need the compassionate care, and I think that's the reason you are here, and your talk will make it so that the entire India will use this technology and also use the compassionate care. It's not only for eye; it's for all branches across, and we have a Tele-Ophthalmic Society, and we have a Telemedicine Society of India. We have Echo India, which is a great NGO, which has a platform, and Dr. Sandeep Palla and others are representing. And we have also Indian Medical Association with about 200,000 doctors. That is Dr. Jailal as the president. And with this, we want to listen to you. And we also have doctors from Kanyakumari, Dr. Jailal, and from Kashmir, Dr. Abhishek Sachdeva. And we also have from Kutch to Arunachal Pradesh. So we are covering the entire of the country. And I think I just sadly read what Dr. Fauci has written to India, saying that shut down the country and you will be all right. So I don't know what is the answer. But I think instead of that, instead of shutting down, I think we can say break the chain. And that's what we want to listen to you, Bowman. And Bowman has kindly agreed that he wants a lead from all of us, where we have experts from various branches. And he says you can interact with him even during his talk. And we have the greatest institutions, Shankar Nethralaya, then Arvind Eye Hospital, Madurai, then also from LV Prasad, Hyderabad, and also All India Institute, and many others, right, from individual doctors. So I think your words of wisdom supporting the patients and not doctors, and we are there all the time to serve.
What kind of words of wisdom can I give, Doc? My mother always tells me, when I perform in the movies and some review comes out, she always tells me one thing, and it stays with me, and it gives me a sense of humility. It gives me a sense of purpose, that when you act as an artist, as an actor, as a performer, we are always looking for that dream role that we can go out there and show the world how good we are as actors. Dunia ko prove karenge ke main kitna acha actor hu. But she says that is of no value, because that's the only person who's happy in all of that is you, because you are only satiating your own ego. You are given a talent not for you to feel that you're a great actor. I'm not a great actor or a good actor, but you're given a talent to make people happy. And you see, the moment you move away from that and you feel that it's about you and your performance, or maine aise kiya, maine waise kiya, I think that has no value to the people who are watching you. If you do not bring happiness and joy and inspiration and empathy and kindness, then what good is that talent? It's only good for you and your own ego. So I genuinely say that, it's the best way to bring down your ego is to make fun of yourself and put yourself in a humbler situation. I'll give you a quick anecdote. I hope you don't mind in all this talk. I have nothing more to say except some anecdotes to bring a smile upon our faces. When you asked, no, I said, please introduce me because people may not know who I am. They don't have to know who I am. That's also part of our ego that people should expect. Picture nahi dekha, Munna bhai MBBS nahi dekha. Main bhi to doctor tha. And when I go to hospitals, many times all the housemen and all, they joke with me and they give me a stethoscope and put it on your neck, sir, let's go on our rounds. Or maybe rounds pe nikal jata hu. I go on the rounds, hello everybody, anything. I look at chart and I play the fool with patients. And I tell you, I feel it's a blessing, not just for the patients, but for me, that gives me so much joy that they are smiling. And that's what someone like I can do. That's all. I was once on a flight and I was sitting early morning flight, and one guy was talking very loudly on the phone. Zoro se baat kar raha on the phone. And it's really disturbing in the morning and it's rude. All right. It's also very rude. And then he spotted me, See how ego comes into play, huh? Just see. So he spotted me. Arey! He got so excited. He's saying, Arey, mera favorite actor, dunia ka sabse favorite actor. And I'm feeling very good. Main dunia ka sabse favorite actor hai uska. Then he tells the guy on the phone, ek minute ruk ja, I'll make you talk to him. Arey wah, make you talk to him. Okay, no problem. Then he comes, main baat karwata hu, ruk ja, ek minute. He comes to my ear and he covers the phone. He comes to my ear and asks me in ear, Arey bhai sahab, aapka naam kya hai? I said, see how wonderfully my ego got punctured. Because I was expecting dunia ka sabse favorite actor. Usko naam hi malum nahi hai. He said, doctor, yeah, Dr. Mamu virus. Well, now I don't mention the word virus. Road pe jaanga, load marenge mujhe, ghar ke andar jao, virus ko bhagao, iske liye main lockdown mein bahar jata hi nahi, virus ko bhagane mein, So that's the little light-hearted part. I just like to introduce myself with a little bit of light-heartedness. I'm joining my hands and for this very reason. And that is, I saw a wonderful photograph, but unfortunately, I can't show it because I don't have sharing. Dr. Natarajan did not allow me screen sharing. Koi baat nahi, mazak kar raha hu, doctor. Aap seriously mat lo meri sab baatein. There was a beautiful photograph of a healthcare worker. Have you seen that photograph? The healthcare worker, and there's a baby in her hands. And that baby is shaped like the map of India. And that's what's happening today. I'm emotional. I'm sorry. I'm emotional. And that's what's happening today. That the medical community, the country is sitting on the shoulders of the medical community. Everybody is saying, we are all saying, save my friend, save my uncle. And we are all desperate in what's happening in the country. But I also say, please, somebody has to protect those people who are in the hospitals, who are working for unbelievable amount of hours, who are working for this unbelievable amount of hours, and they have nobody to complain to at the risk of their lives. And nobody is asking about them. And I just want that I'm telling part of that community, you have no idea what it feels to be in awe and appreciation of the community. Having said that, that's another crisis that we are dealing with, and with God's grace we'll come through. But this other crisis, what about patients, not just COVID patients, but patients who may have other emergencies? There are so many people that I know, apart from COVID, are rushing off to the hospital for this operation, that operation. Who's dealing with that? And here, all of you have stepped up onto the plate to give help to people who may or may not afford help across this wonderful format. I don't think I would have ever met you otherwise. Of course, Natarajan will drag me to one of the conferences and I'll come. Aisi baat nahi hai. But this is an unbelievable thing that you all are onto, and I am utterly grateful for members of the non-medical fraternity who, because of lack of knowledge, always live in fear, always live in anxiety, and always tend to panic a little bit. That's it. And you can't blame us. You can't blame us. When you hear the words from the doctor, you feel a lot better. You feel that's what a doctor does. Good God. I just want to add before I go one more thing. And this is not for you, ladies and gentlemen and doctors. I'm sorry. It's for, if this voice goes out to the general public, and I hope it does, that when the vaccinations begun, there was a whole plethora of people from the university of WhatsApp forwarding. It's a university of WhatsApp forwarding who would send me messages about the problems with the vaccination. Ye mat karo, wo mat karo, aise mat karo, aise. And they are the COVIDiots. They are the COVIDiots. We call them anti-vaxxers. I call them, who said, let's see how it works out. When I was a kid and the vaccination people came to school and give me vaccinations here, sometimes Big Boil would come up, but nobody questioned anyone. Nobody questioned and said, what's going to happen? You're going to be safe. No polio, no smallpox, no smallpox, no whatever that would have spread in the world. And a lot of people would be walking, children would have been walking differently. But no one questioned them. You know why? Because that university had not opened then. The university of WhatsApp forwarders. So I just think you've got to have faith in the professionals, faith in people who have spent their lifetime studying this subject, and not doubt. 99% of the cases of people who are struggling today are the ones who had the opportunity to take the vaccination and did not. So what they are doing is they're kind of denying the position of someone else who did not have the opportunity to take the vaccination to get a bed in a hospital. I'm sorry, it sounds a little hard, but this is the truth. This is the truth. I'm sorry. I'm not telling you guys. Of course, you gentlemen and lady ma'am, you all know what I'm saying. But having said that, my little tirade, थोड़ा मजाक भी किया, थोड़ा serious भी बोला. उससे ज़्यादा मुझे और कुछ नहीं आता है. मम्मी ने जो सिखाया था, सब लोग को हंसाओ, सब लोग को खुश रखो, यही मुझे मालूम है. आप लोग सब लोग की जान बचाने निकले हो. बस, I am grateful. God bless you all. I think I've spoken my 15 minutes. And if there's anything you want to ask me, please go ahead and ask me. Thank you so much. Thank you.
Dr. Subudhi and Dr. Rajiv, Dr. Sunil Shroff, you want to ask?
Yes, I would like to ask a question to Mr. Irani. Mr. Rani, with COVID, with this pandemic, we need to have physical distancing, and telemedicine as a form has been a great boon.
Yes.
Have you personally used this medium for a consultation with a doctor?
Yes.
And we want you to help us to promote this. And there is a fear as well with the public that they are not going to see the doctor, but this has been a great medium for communication. And we just want you to say a few lines on that, on telemedicine consultation, which you may have encountered yourself and your experience. Thank you, sir.
Absolutely, Dr. Shroff. I think that I have consulted. My daughter-in-law has consulted. Dr. Natarajan will tell you. My granddaughter has been consulted. Of course, she didn't speak. She's only 2 years old. We spoke on her behalf. वैसे ईरानी है, बहुत brilliant है, ऐसी बात नहीं है. But sorry. But the fact is, the work gets done and fast. I think even these are not the best of times, but even the best of times, sometimes it may not be a bad place to go. Many of the film promotion, let me give you an analogy. We do film promotions, okay? You have to drive God knows how many hours in traffic and go and sit in one room where all the press guys have to come. Today we are doing it over here. Why can't it be transposed over here on the Zoom call? I am teaching every day, every morning at 11:30. I teach for 2 hours every day using our time well. For now 315 sessions. I think I would have had great difficulty finding time in finding a classroom and jama karawing all these students. So the education that we have managed to impart on my subject, acting and screenwriting, why not use? I tell you, technology should be embraced, and all great things come out of adversity throughout history.
Absolutely.
All great things come out of adversity. Saying, "Nay, I'll meet the doctor only when I see him face to face. Then I feel that maybe I get paisa also." That's all nonsense. That's all nonsense. And you can't even meet the doctor. Excuse me, just now you can't. There will be some cases you might have to go. But for consultation, what's the harm? Why the doubt? Why? Again, Dr. Shroff, I'm blaming it on the University of WhatsApp forwards.
Thank you, sir.
Right,
Thank
sir.
you so much.
I posted a WhatsApp syndrome last year. I made a new diagnosis called WhatsApp syndrome. It affects your vision. It affects the computer vision syndrome. And third is psychological distress, reading all the news and all this nonsense and various myths and no facts at all. And Facebook banned it. And I had a webinar called WhatsApp syndrome, and the Facebook banned that.
And it gives people a false sense of achievement. If I see a WhatsApp video, I see 10, maine first class, first standard I passed. If I see 100, I am now a graduate. You see, that's the problem. Apart from the fear that it spreads, I can't tell you how people make life's decisions based on somebody else's curated WhatsApp video.
Yes.
If you make
Mamu, you are
Munna bhai
amazing.
Yes,
Mamu, you are amazing, sir. You are amazing.
Thank
Mamu,
you.
you are amazing.
Thank you so much, sir. Yes, Dr. Shroff, you were saying something.
I was saying that if you ever make Munna bhai to do use telemedicine as a form of consultation on the Munna bhai
Done.
thing, you know,
Done. Oh yeah.
and give us help to promote this great kind of concept to reach out to the ones who are not accessible.
I surely will. I just hope that in Munna Bhai 1 as a doctor, I did not let you all down. I did as much as research as I could, but I hope I did not let you guys down.
Actually, I mean, whenever anybody calls, including Mr. Bowman, and I think he was very kind enough, and even prescriptions were typed and sent, and he followed it, and I think happily everything is treated well, and so I think Mr. Bowman is a beneficiary of telemedicine.
Yes,
And
I
it's-
am. My grandchild was ill, my daughter-in-law, myself, I consulted. What more do you want? And over a period of time, follow-ups. Yeah.
Yes.
WhatsApp forwards actually got to me. I became nervous, and it helped. It affected my health because I used to actually read them. Now, anybody who opens a WhatsApp, I don't want to hear it. I don't want to hear of it. They're all geniuses in their home. Let me be a peaceful man in mine.
Thank you so much.
Mr. Bowman, can you be a brand ambassador for our 2C?
You tell me.
Teleophthalmology.
Anything that's progressive, anything will benefit anybody. Dr. Natarajan knows I'm there.
Thank you. Thank you very much. Thank you, sir. Thank you.
Now, Dr. Sandeep, you want to say something or ask
No, sir.
something?
I think, Mr. Bowman, very good evening. This is Dr. Sandeep Bhalla. I'm representing Eco India. It's too good to see you. And I think if the investors like you can do the communication in this type of crisis movement, because people are takers are looking into who are the people, those who are spreading the message. And communication plays a greater role during the pandemic movement. As you say, this is a world of infodemic, and WhatsApp University has been opened up. But I think the right thing is the right messages from the people like you. If we can disseminate, we can get multiple people to get the right things to go ahead. I think this is the way which we look from the investors, people like you. So thank you for joining us, and thank you that you are here and you are doing a great job. Look forward to get your support for benefit of our in future also.
Thank you so much, Dr. Bhalla. Thank you so
Thank
much.
you, sir, for spending much time with us.
Thank you for allowing me in this august company.
Yes, sir.
Unless I had not done Munna Bhai, aap log mujhe idhar bithate nahi. You would never. Well, I am very grateful for that one role I did. You all have allowed me to sit over here.
No, that Munna Bhai role had a lot of strong messages to the country and society.
Absolutely.
It is from your mouth that became so popular and so much imprinted into the mind of Indian society. That is your greatness, sir.
Thank you, Dr. Patnaik. Dr. Sachdeva wants to say something.
Yes, sir. Sir, good evening. Sir, I am Dr. Abhishek from Jammu. On a lighter note, I just wanted to ask, sir, ये form भरना जरूरी है sir क्या?
Oh boy.
No, sir. I want to tell that because of this teleophthalmology and tele thing, one more advantage that is that there is no need for these forms and all, and the patients doctors are much more accessible to patients directly.
Right. Yeah, but today, unfortunately, it's more than forget about the form. One can't even get in. But this will help and take the burden off a lot. It'll take the burden off.
Medical.
Yes. Yeah.
Dr.
Yeah.
Kim, you want to say something to Bowman?
You
Kim
know,
is
thank you, Dr. Bowman. It was really, really
I
an
got all
excellent.
Bowman. I fooled you all. I fooled you all.
You are on that roll today. But you made an excellent presentation. I mean, your talk was very, very inspiring for a very enthusiastic and brings a lot of inspiration for us for the work we do. I think it really was a wonderful talk. Though you said it in all jovial way, I think it really mattered a lot to all of us. Thank you.
Thank you, sir. You know, I've been taught in screenwriting, if you want to pass on a message, there are two ways to pass it on. One is through drama
Yes.
or conflict, and one is through humor. There are no other ways of passing on a message. If you tell me, give me a message, nobody's listening. But through drama, a little bit of conflict, and then you slip it in, or humor. It's one of the principles of screenwriting.
No, since you are in the Munnabai MBBS and you are in the anatomy hall of the JJ Medical College, one more thing in ophthalmology, in part of anatomy, the front part of the eye has called anterior aqueous humor. And then the back part, which I have specialized, is called the vitreous humor.
Vitreous humor. School में पढ़ा था. Aqueous and vitreous. ऐसे मेरा ईरानी है लेकिन थोड़ा अक्कल है. ऐसा नहीं.
नहीं, इसमें humor था.
हाँ, humor हाँ, but मेरे को याद है. वो भी याद है. Aqueous and vitreous. So ईरानी लोग सब लोग समझता है बेकरी वाला है क्या समझेगा. थोड़ा अक्कल है, ऐसी बात नहीं है.
Undoubtedly.
From Arvind Eye Hospital and Rajiv from Shankaracharya.
Thank you.
Thanks. It was really a great talk from you. The last part which you said, we need to learn a lot about how to give a message about eye conditions or even the various diseases to a layman. And what I learned, the two things which you said, humor, or it has to be a dramatic one.
Right.
I think that is something good learning which I got from the last few sentences.
I think we should keep the dramatic one for Saas Bahu serial, but I think we should use the humor.
That's a big challenge, telling to a lay public about the diseases itself, the importance of it, the need for a disease screening. I think those messages we need definitely. Dr. Bhalla would be from Eco India. They are trying to develop some communication messages. It would be great if you can help them in doing that too.
He actually voluntarily supports our Roti Foundation, which I got here, which we do daily 10,000 meals a day. He himself calls and tells Shivanandan and he gives us, and I'm a trustee there. So same thing he will do for us. And in 1 second, he agreed to WhatsApp now. I didn't even call him. Then I asked him, can I call you? And he called me back. So that way he's really great. Padmaja, you want to say something? Because I think we have taken enough time from Bowman.
So nice of you. Thank you, all of you. God bless you from my family.
Thank you, sir.
Thank you, sir.
Yeah, so Upendra, you on the camera. You want to say something? He's a technical guy who's doing the program.
Yeah. Thank you.
Bye-bye. Thank you, Bowman. I think really this way we do the clap without noise. So great. Thank you very much. Yes.
Thank
See you,
you.
see you, ma'am.
He was
See you,
just
Dr.
taking a
John.
screenshot with the Bowman sir.
Thank you, sir, for coming and joining with us.
Thank you. I'll
Bowman,
be back.
you want a screenshot? 1 minute.
Sorry.
Can everybody be on the camera so that Dr. Gogia,
Photograph tayar, okay.
Dr. Sandeep, Dr. Ganesh Joshi, Sandeep, where did he go?
No, sir, no.
Here only.
No,
There
not
only.
on the camera. Yeah, okay. Dr. Ganesh Joshi, he wants a group photograph. I think it's Upendra, you are taking the group photograph?
Yes, sir. Yes, sir.
Come on, Upendra.
Okay.
Done it? Thank you, sir.
Yes.
Thank you, sir.
Thank you very much.
God bless
Thank
you all.
Bowman.
God bless you all. Thank you.
Thank you very much, sir.
Thank you.
Thank you, Bowman. He's gone. Okay. So off to you, Rajiv and Sheila.
So it was great listening to Mr. Bowman Irani. Let's come back to our scientific session. Dr. Sheila?
Yeah. I'd like to introduce our next speaker, Dr. Sunil Sharaf, Senior Consultant, Urology and Transplantation, Madras Medical Mission Hospital. He's the President of Telemedicine Society of India, Tamil Nadu chapter. He has received many awards and done a lot of research work. Over to you, sir.
Thank you.
I invite you to deliver your lecture.
I'm audible to all of you, I'm sure. I've just spoken
Yes,
to
sir. Yes, sir. Yes, sir.
Mr. Bowman Irani. So I have 12 minutes to cover a document published by Government of India. It's a 40-page document on telemedicine practice guidelines. No financial disclosures. The guidelines were first published by the MCI or the NMC on 25th of March. And soon after, on 14th May, they were gazetted, which means that we today have a legal instrument which is available to practice telehealth in India. What are the requirements to practice telemedicine in India? We need to be familiar with the guidelines, its processes and limitations.
Sir, we can't see presentation.
Can't see the, sorry, slides, is it? Sorry, beg your pardon. I may not have shared my screen, sorry. Can you see my screen now?
Yes, sir.
Yes, sir.
Yeah, so these guidelines were gazetted on 14th of May by the Government of India, which means that today we have a legal instrument for practice of telehealth. And what are the requirements to practice telehealth in India, telemedicine? One, as an RMP, as a doctor, you need to be familiar with the guidelines, its processes, limitations. There is a mandatory requirement to do an online course within 3 years of passage of these guidelines. As Telemedicine Society of India, we conduct training exercises for the RMPs, and we have been doing this, last year we did many such courses. We've done training for the armed forces as well. And the next training will happen in May sometimes, the 3rd or 4th week. Do be in touch with me. You can mail me and I can send you what are the dates. The purpose of these guidelines is to use telemedicine as part of normal practice, as already been said by the previous speakers, and it provides practical advice to doctors, and all models are encouraged. It provides the regulations on how to be safe when you practice these telehealth as such. What it does not cover, it does not cover for practice outside India. No remote surgical procedures are allowed. No prescription of scheduled X drugs or narcotics. Does not allow for research and does not cover hardware, software, standards, and so on. Hopefully, that will be defined soon. So I'm going to just stress on the important elements in these guidelines. There are 7 elements in these guidelines which a doctor needs to follow. And these include the context of the telemedicine, the identification of the doctor and the patient, the mode of communication, the consent process, type of consultation, patient evaluation, and patient management. And this is the familiarity which you need to have. What is the first is, what is the context and what is suitable for a situation? It is left to the doctor to decide what is best suited under the given circumstance. And you can decide what you want to do. If you feel that a face-to-face consultation is required, then ask for it. Don't go ahead with teleconsultation. It's your wish. You can either do counseling of a patient, give health education, or you can prescribe drugs after evaluating the patient and having a provisional diagnosis. I'm talking to a group from, of course, ophthalmology group, and you know about diabetes epidemic, and I'm sure you people will talk about it. You know the number of diabetics in the world. And diabetic retinopathy, as you know, is the commonest cause of preventable blindness in the world. And in India, with the 72 million diabetics which you have, 7 million which have a vision-threatening diabetic retinopathy, but we only have 15,000 ophthalmologists. And this is one of the solutions which has been given forward of screening diabetes, with a technician, with a camera, and categorizing these images using AI. And if there is diabetic retinopathy grade 3 or higher, then getting a ophthalmologist to see such patients. So great applications for using telehealth. And I think teleophthalmology as a society in India can use this as a group to promote this on prevention of blindness. The second part of the element is that there needs to be an identification of both the doctor and the patient. No anonymous teleconsult is allowed by the guidelines. Why it is important? You know that there are a lot of doctors in India practicing allopathic medicine without having a degree. And with the patient, you cannot be giving a wrong prescription to a wrong patient. That can be a disaster. So there is a reason why you should identify the patient. Regarding the mode of communication, Dr. Gogia has already stressed on this, but it really depends. The technology itself is a function of bandwidth, the latency, the delay, and the complexity of care. So for a routine consultation, an email like an asynchronous consultation could be enough. When you want to forward an image, asynchronous consultation could be enough. But if you want to do a video consultation, then you require higher bandwidth, there's higher latency. Whereas if there's a procedure to be done, then even a more higher bandwidth is required. So, depending on what you want to practice with telehealth, the requirement will change. The advantage of apps, one of the great advantages, there are 300,000 apps out there. But one of the great advantages of app for teleconsultation is it takes care of all your pain points, like consent process, consulting, prescription, payments, and so on. But each doctor should choose each specialty should choose their own app what they want. What about the consent process? The consent process can be implied or explicit. When a patient walks into your clinic, then the consent is implied. That means the patient has come to consult you. And this is the same thing happens in teleconsultation also. When a patient initiates a consult, then this is implied that the patient wants to consult you. So that consent is already taken in that kind of process. But if there's a caregiver who wants consultation on behalf of a patient, then you need to get a written consent from the patient, and this is called explicit consent. And this needs to be recorded and preserved. The caregiver should be, or it could be any family member, any person authorized by the patient to represent the patient. And they need to give, as I said, a written consent. They can just write, I agree to for teleconsultation, and they can just tick that. And you should preserve that. There are two types of consultation, first consult and follow-up consult. What is the first consult? First consult is a consult when a patient has, patient consults you first time, obviously, or consulted you, but not more than 6 months have elapsed since the last consult, or the patient consults you for something new. That is the first consult. And then there is a second consult of, which is a follow-up consult. In emergency situation, can you offer telemedicine consultation? Yes, you can, but the role is very limited. You must tell the person to go for in-person consultation, visit the nearest hospital. In an emergency used to save life, you can give a first aid, like you put a tourniquet, you can advise the patient to stop bleeding and so on. But you can't go beyond that. And these kind of things, again, needs to be recorded and documented well. The sixth part is about, required for patient evaluation for a consult. The evaluation has to be similar to face-to-face consultation. Already stressed about this. The first principle is do no harm. If you can't do good as we normally follow, and get all the possible information like history, examination, everything in the consultation. And if you feel a physical examination is critical for a judgment, then ask for an in-person consultation. Don't go forward. So this is the same as face-to-face consultation. It doesn't change. If you feel that the patient needs to see you, ask them to come for in-person. So you need to practice safety. That's the utmost important thing in teleconsultation. What about management of patient? Management can be towards prevention, diagnosis, treatment, or education of the patient, as I already said. As far as prescribing medication is concerned, take utmost precaution and discretion, just like you would be in normal times. Ask for allergies. Make sure you have a diagnosis, at least a provisional diagnosis, before you prescribe drugs. If you don't have provisional diagnosis and prescribe drug, then it will be, something which will be unethical and against the principles of telehealth consultation. As far as the medications are concerned, there are 4 lists. List O is, over-the-counter medication, as you would normally, you can prescribe them on any consultation by just audio consultation or any consultation. And then there's a list A, and this list A is only to be prescribed by video consultation. You need to have a video consult if you want to prescribe this medication. It includes the over-the-counter medications, plus like ointments and everything, of course, and plus also for some chronic illnesses like hypertension, diabetes, asthma, and there is work, etc., which enlarges the scope, but this needs to be better defined. And recently, the government of India has, when they passed the guidelines, they also have included some antipsychotic drugs in list A. And then there's list B, which you can prescribe as a follow-up medication. You can add on, you can tweak the medication and so on. And then the prohibited medication, which you are the Schedule X and narcotics, except for the ones which have been passed by the government of India, you should not prescribe. For as an ophthalmologist, ointments are free to use, so you guys will have probably less challenges than practitioners like us. As far as e-prescription is concerned, when you send an e-prescription, you can send it via email, but you need to take a consent of the patient. And you need to scan these and preserve these if you're sending an e-prescription. You can charge a fees for consultation, no problem, just like in person. Don't charge exorbitant money. Health insurance companies also have come forward for reimbursement. There's a fear of breach due to technology. This is a challenge which is always going to be there. You need, as a practitioner, to take some precautions for this so that this kind of breach doesn't happen. Use websites which we have a security key. Use, if you're using cell phone, mobile phone, use a passcode to make sure that if it's just lost, nobody, kind of hacks it. Maintain your digital trail, how long you need to maintain, what you need to maintain. The guidelines say that you need to keep the phone logs, not the recording. You need to make email records, chat records, like if you're doing a WhatsApp, you need to keep those records. But as far as video consultation or phone consultation is concerned, you don't need to record them. You just need to keep the logs of these consultations and keep them at least for 3 years. If it's a medical legal case, keep them for 10 years. And as I said earlier, that if you have prescriptions and so on, do preserve them and preserve all this these like images and diagnostics you're using in teleconsultation and reports. As far as medical ethics misconduct, they talk about that as well. That do not solicit or advertise or give inducement for teleconsult. If a patient is willing to come for in-person consultation, don't come for teleconsultation. Don't misuse patients' images, especially private images on the social media platforms. Be very careful, and the penalties for this kind of thing will be similar to what the MCI's guidelines say. Other thing is, so these are basically, I've tried to, in the short time which was given to me, I've just tried to capture the essentials. This is the summary. The telemedicine, telehealth practice is now allowed in India, of course, as I said. And as a registered medical practitioner, you're empowered to decide what form of consultation is appropriate for the patient, whether you can do teleconsult or not, or you want to do, in-person consultation. And you can do diagnosis and treatment using, this technology. You can prescribe medications as well. We are hoping that soon we'll have a version 2 of the telemedicine guidelines. There are a few lacunae, and we hope these lacunae will be overcome in the, the second document, which may come soon. So thank you very much for your attention, and I wish you all the very best. So I've tried to finish in my 12 minutes to share with you.
Thank you. There are a couple of questions probably we can take at the end of the session. We can take few questions.
Sure, anytime.
Yeah. We'll move on to the next talk. The next talk is by our president, Professor S. Natarajan. There are no words to really introduce him. I know him as a good friend, a mentor, and I would say who has a passion for both teleophthalmology and for diabetic retinopathy. Welcome, sir. Welcome for your talk.
Thank you, Rajiv. I have to, yeah. Thank you. So my talk, I have chosen the same topic as I compared both the diabetic retinopathy and teleophthalmology, diabetic blindness free India 2025. And this I took it. I know it looks like an impossible dream with the 77 million diabetics with 40 million not diagnosed. I keep reading papers from Mohan Vishwanathan and many things with the Kim, Rajiv, Padmaja and Dr. Sheila John. But I've decided because Swami Vivekananda said he got his life's mission after he meditated in the Vivekananda Rock Memorial. Same thing I did thrice in the last 6 months. So today is my grandfather's birth anniversary. He was born on 1st May 1900. So I'm happy to collaborate with Echo India, and I'm sure I'll be able to achieve, even though it's a small beginning today. But I think I've learned 6 or 7 P's: perseverance, persistence, passion, patience, prayer, precision, and so I don't have any financial interest. So I run an NGO started by myself, but the name was given by my friend Dr. Abdul Kalam Aditya Jyot Foundation for Twinkling Little Eyes in 2005, and he has visited several times. And I have my friend Mr. Shivanandan here. And this is a mobile van for diabetic retinopathy screening, which had the Zeiss camera, thanks to the World Diabetic Foundation. And we also started the first March in 2014, thanks to Mr. K. Chandrasekhar, the CEO of Forest. And as I said, no, and then you can see my, that time, around 6 years back. So around 97-year-old, my grandmother, my Swarna Tamal and Shivanandan and Mr. Ravichandran, my father also, who was there. So I think we started this diabetic retinopathy screening taking the fundus camera on the motorbike, first of its kind in the world. And we all know 14th November is the World Diabetes Day. And now with the Smart India and Dr. Shobha Shiv Prasad and Tara Prasad have given me a homework that we'll do another wonderful program on World Diabetes Day this year on 14th November. So as the president of All India Ophthalmic Society, thanks to again Rajiv Raman and Kim and all my friends, Dr. Subhuti, Suresh, and Dr. Maipal and others from All India Ophthalmic Society, I made this program called Stop Blindness. The word acronym stands for Screening through Teleophthalmology to Prevent Diabetic Blindness, and I called it in Hindi Jyot Se Jyot Jalao. And we all know that diabetes is an epidemic happening, and diabetic retinopathy is the fifth cause of blindness globally. And our Dr. Babu Rajendran, again past president, who gave for IMA and All India Ophthalmic Society, now it's called PTP, the Prevention of Diabetic Blindness, where Dr. Subhuti is a part of it, Dr. NSG Raju. Diabetes invariably affects both eyes. Test your eyes soon. In spite of several publications and several, they're saying people with diabetes do not know that it's a microangiopathy and you can go blind. You may go blind. So IDF, and this is the statistics, and this Dr. Shroff also mentioned, and in this you see the 77 million. So I go back to my medical college days, the PSM department, where I'm the immediate past president of Organized Medicine Academic Guild, where the preventive and social medicine should have been in the forefront for COVID, as well as the infectious disease people. And same thing is for diabetic retinopathy or any disease. Prevention is better than cure. So I have a video. As President of All India Ophthalmic Society, I would like to thank the International Advertising Agency for starting this competition for making a campaign on preventing diabetic blindness. And I also like to thank Allergan for the generous support to make this public initiative movie to create awareness on diabetic retinopathy and how to prevent diabetic blindness. So are you a diabetic, hypertensive? I think this should be put in every clinic in India.
The world will forgive you, but will you forgive yourself? Diabetic blindness is preventable. If you're diabetic, you need a retinal checkup to prevent vision loss.
So this was a public service initiative to prevent diabetic retinopathy brought by All India Ophthalmic Society, International Advertising Association, like Mr. Bowman Irani. I have Mr. Ramesh Narayan, who has done that for me. So the whole plan of action is screen, diagnose, and treat. And as we take it from the cancer screening, where we just don't diagnose and leave them, we have to treat. We are having problem in convincing the people, but I think we have so much of we need a multidisciplinary approach. But still, I think our idea, as Dr. Shroff put it, We have actually one ophthalmologist per 100,000 population, and we actually have 23,000 ophthalmologists as members of All India Ophthalmic Society. We expect another 5,000 or 10,000 who are not members. So maybe 30,000 ophthalmologists we have for 1.3 billion population. And there's low awareness or ignorance. And 70% of the Indian population resides in rural area or urban slums. And we have 6,47,757 villages. I don't know how do we reach it. And I think probably Echo India, Tele Ophthalmic Society of India, and All India Ophthalmic Society can reach. And thanks to Echo India, and I'm having a ray of hope, and I can see the light at the end of the tunnel with Echo India collaboration. The technical difficulties which Dr. Joshi mentioned, unreliable internet coverage, deficit in supply of electricity. He mentioned Bhutan, but even in remote parts we have problem. Shortage of trained medical staff for operating conventional fundus cameras and portability of conventional fundus camera, and that's the problem. And here I like the statement, the role of artificial intelligence, and I always say that intelligence is the capacity to analyze, think, make a decision, and categorize. And artificial intelligence involves formulating a specially made algorithm according to our needs to develop this capacity and include it in an electronic device like smartphones. So this is I cover any camera. There's a Remedio fundus on phone, can be mounted on a bike like the Forest, can be mounted on any table, and you can also use it as a handheld, and it's a chargeable. So you can have the mobile phone chargeable, and you can have the device chargeable, which is the infrared device. And I coined this term called ABCD. That means anybody can screen diabetic retinopathy. I got it from the movie Anybody Can Dance. And so I think anybody can be trained to do screening for diabetic retinopathy. And that's what I want to say. And this is, you can see how we have the 9th standard class or a school dropout, boys or girls who are working with me. And we did a trial, and now we published this in JAMA. And we are also working with the Bombay Municipal Corporation with 24 wards and 20 million people, where the diabetic the medicines are given free. And you can see that blue things, which shows the AI, which can be applied, which identifies the abnormal lesions. It has to only select and apply the picture on the offline AI, where it comes on the mobile, whether this patient needs referable diabetic retinopathy or no need to refer. So it only classifies two groups. Whether they don't call it normal and abnormal, they say referable and non-referable. If it is non-referable, the patient is asked to come 6 months later. If it is referable, the patient is referred to the nearby clinic. So this way we can use non-medical, non-technical people. That means we can train any illiterate person in the country, and you can compare this fundus photo on a phone as well as Zeiss, which is a 40 or 50 lakh camera. And this is how the AI, which sees the blue color, which picks up the color difference and then picks up the offline AI, which is developed by a company called Meteos in Singapore. And now the Meteos is taken over by Remedio. And I'm trying to work with the IIT Chennai to make it more economical so that we can. So this is a research question we had. Is AI reliable to pick out those in need for seeing an eye doctor? And that's what was published in JAMA Ophthalmology as an original investigation. Diagnostic accuracy of community-based diabetic retinopathy screening with an offline AI system on a smartphone. And this was the first of its kind. And that was a pilot study. And that was the most viewed in 30 days, 4,004, and most cited in the last 3 years. And the reliability rule of non-diabetic retinopathy case drops to 81.9%. But referable diabetic retinopathy case were still correctly marked as with 100% reliability. So reliability of AI for screening population for diabetic retinopathy in need of eye checkup by an eye doctor is 100%. So it was reliable. So the advantage of using AI, Dr. Ganpati mentioned you don't have the technology, but I think even though we are also developed, we are also trained before the AI and before the computers, and many things were used and the technology, but I think we have adopted. And I'm very happy to see my mentor, Dr. Bajanath, using the iPad. And he's also the founding president of Telemedicine Society of India, which is a great thing, which I learned from the Telemedicine Day last Sunday. So advantage of using AI, I think easy referral of referable diabetic retinopathy cases, greater awareness about diabetes, its effects and importance of regular follow-up without anybody who doesn't know English. They can do this because everybody in India has a cheapest or economical smartphone. They know how to book a railway ticket through IRTC or PVR for a movie, or order a Swiggy and order something in the pay phone and Google Pay, everything. So you have a great chair time for the referable diabetic patient by the eye doctor, timely medical surgical intervention to prevent complete loss of vision. I want to submit this to the UP Chief Minister, where instead of having the Romeo police, they can have these people to use this as a job, so that you have more job opportunities and develop a non-skilled worker to a skilled worker. And Arvind has done a great extent in developing 8th standard girls as a vision technician, like that. So I think the point to remember, trained and employed youth of India, even with minimal education and no experience in retina photography, to reach out to save vision of millions, and we can give them the pride of doing something for the health of India. And it is independent of electricity and internet, because you can charge and take it, you can work for 8 hours and come back. And better chat time offered to the referred cases, and timely treatment in preventing blindness, because out of 23,000 eye doctors, only 1,000 or 1,500 may be doing laser and injections. Rest of them are doing cataract and other eye care, because we also have to do other eye diseases we have to take care. So join hands for this monumental revolution, fight against blindness from diabetes through telemedicine, telehealth, teleoptometry, teleophthalmology. So again, I remember my grandfather, Dr. Nataraja Pillai, who was from Madurai. So he was very close to the Dr. GV and Dr. Arvind family. So I'm happy I met the entire Arvind family from 1960. Even though I was 3 years old, I remember that, and my father and myself. So I calculated that because my grandfather worked from 1930 to 1977, and my father from 1955 to 2015, and then myself from 1984 from Chakrakala till now, and I'll go on. Inspiration is my Guru, Swami Vivekananda. Arise, awake, and stop not till the goal is reached. And Swami Chinmayananda, whom I met in 1977 as the General Secretary of the Madras Medical College, he mentioned, keep pushing the goalpost, and the goalpost now is 77 million diabetic. By the time 2025 happens, we are already in 2021. In the 5th year, it may become 100 million, but so what? We can use all the youth of India to do this, and we have 104 crore Indians who are between 18 years of age to 40 years of age. So we have so many people to do the screening, and then they don't have to do anything except using the mobile on an infrared device. And as I said, I don't have any financial interest. So I thank the opportunity by Eco India, Telemedicine Society of India, and also the Tele-Ophthalmic Society of India. And and I thank Eco India for this great collaboration. And I hope I have saved some minutes for the other speakers. And if any questions, I'll answer during the panel discussion. Thank you, Dr. Rajiv Raman, Dr. Subodhi, Dr. Sheila John, Dr. Kim, Dr. Padmajan, and everybody here.
Thank you, Dr. Natarajan. Every time I hear your talk, I take one point from there, because there are so many good points, difficult to have everything in one go. Thank you, sir. So let's move on to the next speaker, Dr. Sheila. Dr. Sheila John is there?
Yeah.
Okay.
I'm introducing the next speaker, Dr. Kim, Chief Medical Officer, Senior Medical Consultant, Veterinary Services, Director, Information Technology Systems, and from Aravind Eye Care Hospital, Madurai. He has received many awards, and he has done a lot of research work. And he's a person who has definitely taught me a lot of things. Over to you, sir.
Thank you, Dr. Sheila. I'll just share my slides. Are my slides visible?
Yes.
Okay.
Yes, sir.
Thank you again for this opportunity to share our work on what's happening in teleophthalmology. Well, of course, the COVID crisis made a lot of change, and telemedicine was the only way many people could reach, and this became the way of moving forward. Technology came to the rescue. There were a lot of teleconsultations. Many of the institutions developed their own telemedicine solution to reach to the patients. And many of the IT companies made a big use this opportunity to develop a lot of software programs to reach out to people. And so this is one way it was a positive thing. And as Dr. Shroff mentioned, the telemedicine practice guidelines came again as a boon to all of us, especially those who have been practicing telemedicine over a period of time. Going back to the topic, we all know that we have the largest number of blind people in the world, and unfortunately or fortunately, many of this could be treated much early. Almost 80% of this preventable if identified earlier. But the problem is how to reach everyone in the need of eye care, especially when we have to reach them early on. How to improve primary care. As I always keep saying, our practice is very reactive, dealing with only those who present by themselves. Bulk of the tertiary care essentially deals with the failures down the line. Had we had a proper or a stronger primary care in all sorts of medicine, especially in eye care, you end up, if you can identify these diabetic patients much early on, even before they start developing advanced stages of diabetic retinopathy, or alerting these diabetic patients about the importance of screening. Patients with corneal trauma, they usually end up in tertiary care centers only after they have treated all sorts of native medicines. If all these could be identified earlier on, we have shown in now using our vision centers how this identifying early these patients, we prevent a lot of these corneal blindness from happening. So why primary care? As I mentioned, we need to reach them early on to prevent any blindness, or preventable blindness is much easier if you can reach these patients early, especially patients with glaucoma, patients with diabetic retinopathy, and other similar conditions like AMD. So the current ophthalmology it's applied mostly in primary eye care and secondary eye care. I consider diabetic retinopathy and retinopathy of prematurity. Tertiary care is when you have consultations between doctor to doctor. So we started this about 15 years back or 16 years back, where we started these technology-enabled vision centers, the first of its kind, where each of the vision centers, which is manned by an trained ophthalmic technician, which will take care of a population of 50,000 to 75,000, where they do not have any ophthalmologist available. These are permanent facilities functioning every day, equipped to provide primary eye care. As I said, staffed by a trained technician, and it provides primary eye care and referral service. So what happens in the vision center? Patients after getting registered is examined by the trained ophthalmic technician, just like an ophthalmologist would do a complete eye examination, including a dilated fundus photo, intraocular pressure measurement using appellation tonometry, and upload all of that into an electronic medical record. And then they connect to the doctor in the base hospital, where each of the patient going to the vision centers will get a consultation, teleconsultation with the ophthalmologist sitting in the base hospital. So this, and then we also close the loop to ensure that every patient gets even the medications or even the glasses are prescribed and dispensed there in the vision centers itself, so that the patients need not travel to the city to buy these medicines. So this is like a hub and spoke model, where each of our tertiary care center is surrounded by many vision centers, and not more than 50 to 60 kilometers. Only one of them, Rameshwaram, is slightly further away. This is to make sure if patients need to access tertiary care, they can travel easily. But surprisingly, we found only 10% of the patients ever seen in the vision centers need to be referred to the tertiary care center, and 90% of them are taken care of in the vision center itself. This is the best last mile connectivity in any healthcare intervention, gives access to care since it's locally available. It was surprising to see many patients who never accessed care were able to reaching out to these vision centers. They did not depend on any attenders. There's a lot of money and time saved, and also compliance to care when you advise, even for long-term cases, they're able to go to the vision center. We request even our post-surgical patients to go to these vision centers for follow-up. So we have today we have about 92 vision centers. Today we are almost doing, I mean, at least pre-COVID we were doing 2,000. We in between we reached the same number per day, but again it has dropped to today because of the COVID. But this is one way patients are able to access care, especially in this period of COVID crisis. Tripura, we worked with Tripura government to develop this. This has become a role model for the government vision centers, which is being done in Chhattisgarh, Jharkhand, and even in Bangladesh. Recently, the Rotary Club of Chennai East has started this orange vision centers, which they're working with multiple hospitals, including Aravind, LV Prasad, Shankar Nethralaya, and other centers, where they are planning to start hybrid vision centers, which they have some static vision centers, then they have mobile vision care units where the scooters will take, go to place, door to door, and then they have an advanced mobile vision care unit, which is a four-wheeler, which will do a little more sophisticated screening. This is just the beginning of this project, started, and it's going to be some time before it becomes fully operational. And this is started in Chennai this year. The other condition, which is close to my heart, as Dr. Natarajan mentioned, is diabetic retinopathy. We all know that it is easily preventable if these condition is identified early. Many of us, Shankar Nethralaya and Arvind, had these ISRO-supported mobile buses, which was given up with the increased advances in technology with 4G available today. We don't need these huge satellite vans, which would go into the villages or remote locations, screen the diabetic patients, sense images. For the last 15 years, we have been doing this type of screening in the diabetic clinics, where the technician is trained to take fundus pictures, sent to a reading center, and the report is generated. And within about an hour or so, the report is sent back to the diabetologist. He's able to counsel the patient if there is a need for eye screening. Otherwise, they are advised for an annual screening. At least the patient is aware that his eyes have to be examined. We are also using the primary health PHCs, where the diabetic patients come once a week for getting the medicines. The PHC medical officers ensures that the patients are examined in these visions and in these for diabetic retinopathy, and only then they are dispensed medicine. So they are ensured that every single diabetic gets an eye examination. This is happening in few of the primary health centers here today. Again, this is becoming widespread. There are a lot of business models emerging. One of them is the WellCare Health Systems run by Dr. Sendil. Forest Health is also doing quite a lot of tele-screening using this. Another condition amenable to tele-screening is retinopathy of prematurity happening in premature babies. It's a time-bound diagnosis. If you don't do it early on, the child is likely to become blind. Today, we cover almost the whole of South Tamil Nadu to ensure we screen all the NICUs, both government and non-government hospitals, where our team goes, the technicians, they take pictures, send it to our doctor in the base hospital. We are, with the advent of artificial intelligence, we are now using AI in diabetic retinopathy screening, where the image just dropping in, you're able to get the grading of the images within a few minutes. And this, they can use it for, the earlier, which was taking 1 hour time and also taking away the retina specialist time, today is done with the simple click of using an AI tool. We are now working on to see how with Oregon, how to use AI in retinopathy of prematurity screening. A lot of research is happening on using AI for predicting or progression of diabetic retinopathy, age-related macular degeneration, and many other conditions. So this is going to be the new way of using telescreening in future. This definitely prove how we see patients going forward. So there's an enabling environment. There's a lot of network availability now. All villages have digital connectivity. We have widespread use of EMR, but we need to have more policies that proactively promotes telemedicine, especially revised rules around drug supply chain. I want to thank you for this opportunity. Thank you. Happy to answer any questions if there is.
Thank you, sir. Thank you for the nice talk. We will go ahead with the last talk for the evening. I'll just 1 minute. It's a pleasure introducing my good friend and my good colleague, Dr. Padmaja Kumari Rani. We actually started the journey of diabetic retinopathy together way back in 2002, 2001-2. And she took this path of teleophthalmology and she heads the teleophthalmology at LVP Network. Dr. Padmaja, kindly share your experiences as far as teleophthalmology is concerned.
Thank you, Rajiv.
Padmaja, please.
Are my slides visible?
Yeah, I can see your slides.
Yeah. Thank you, Rajiv, for the kind introduction. And at the outset, I would like to thank Dr. Natarajan and Teleophthalmology Society of India for giving the opportunity to present teleophthalmology experience of LV Prasad Eye Institute. I'm going to present you with an overview of teleophthalmology at LVP Eye Health Pyramid, teleconsultation referral guidelines, and how the corona pandemic has strengthened telemedicine systems at LVPI during and after lockdown, and some innovations and learnings that we have learned to date. LV Prasad Eye Health Pyramid, as on March 2021, we have 206 primary eye care locations called vision centers, 20 secondary eye centers, and 4 urban centers, 3 tertiary centers, and a center of excellence in Hyderabad. We also have 9 partner centers in India and an overseas partner in West Africa with Liberian Eye Care Center. The entire LVP pyramid has been connected by an iSmart system of electronic health records since 2013. This is the fundamental requirement for developing a teleophthalmology system. Pre-corona, we had a strong teleophthalmology of primary eye care with our primary eye care called vision centers, which were connected to command center, which was located at the tertiary center. Post-corona, the entire pyramid of LVP is connected through teleophthalmology. Last year in the primary eye care teleophthalmology used for management of simple to advanced eye conditions ranging from conjunctivitis to eye cancers, 35,000 plus teleconsultations were conducted. In that 10% were managed by teleconsult advice alone, 22% were managed by medical care, and 16% were referred to secondary centers for further evaluation or surgical care. So we have formulated specific referral guidelines for teleconsultation at primary level with an objective of improving the efficiency and avoiding unnecessary referrals. These guidelines were reinforced through periodic workshops for vision technician. Reinforcement of referral guidelines at the primary eye care was done through interactive workshops demonstrating referral indications through the pictures. And these are the media that has been used as a training workshops. Both anterior and posterior segment indications are shared through the pictures. Diabetic retinopathy is another important focus area where we developed an in-house artificial intelligence tool, ScreenRad, which was developed in collaboration with Sigmoid. In the direct efforts were also ongoing for strengthening vision technicians in diabetic retinopathy screening and referral guidelines and fundus imaging. This is crucial for an effective AI tool. We need good quality fundus pictures and robust manual grading as well. Training methodology included interactive workshops. 210 vision technicians were participated, and the actually lockdown period was actually used using a tele education platform like Zoom. And we have conducted these workshops, and the outcome is 60 vision technicians have completed the online diabetic retinopathy certification from the University of Melbourne in just 12 weeks following the workshop. Specific referral guidelines for teleconsultation that can be managed by teleconsultation alone were developed at the secondary eye care level. Similarly, specific referral conditions for all subspecialties also has been clearly laid out so that the teleconsultation can be practiced by the consultants with ease. Another important measure for efficient tracking introduced is referral color coding. So the red means urgent referral within a week, yellow semi-urgent referral, green the conditions that can be managed by teleconsultation. So this is a typical teleconsultation EMR chart in a day typically looks. You can see that, as Dr. Kim said in her earlier talk, that almost 90% were actually managed by just a teleophthalmology advice alone, where are few cases which requires. And this tracking will alert both doctor at the command center as well as the primary care vision technician that this patient needs immediate referral, and and we can actually track the patient until the end. COVID pandemic was actually an opportunity for teleophthalmology. As a teleophthalmology, we call healing from a distance. HIPAA restrictions have been removed. Specific telemedicine guidelines enabling telemedicine were introduced, which was taught very nicely by Dr. Sunil Shroff, recommending mandatory certifications by doctors practicing telemedicine and development of various specialty-specific guidelines. Lockdown period, both at primary and secondary level, more than 100,000 phone calls were made by our vision technicians. Again, fundamental tool which enabled this is a strong electronic medical record database. And 500 teleconsultation happened with the help of photographs taken by the remote rural population in remote rural villages through the vision technician. And there was an immediate WhatsApp group has been formed to just give consultation through the doctor to the vision technician, and they could reach in the month of the May last year. At the tertiary level, we had a sudden decline in the number of patients from an average of 1,500 per day to just 50 per day. And we immediately launched a teleconsulting portal, and telemedicine achieved 3 significant objectives during the lockdown. First was triage, which patients need to visit the hospital on an emergency basis, management of medication and advice, and second opinions based on the review of images and reports. All our faculties completed mandatory certification in telemedicine guidelines of India. LVP teleophthalmology during COVID pandemic included all ophthalmic subspecialty, including telerehabilitation, and all these learnings and experiences were published as a protocols in the peer-reviewed journals. Recognizing the importance of teleophthalmology at the time of pandemic, we launched an app-based telemedicine portal we call Connect Care. With this app, our doctors now can connect with patients by clicking the button on their mobile phone. All appointments are scheduled. It is just like a virtual outpatient clinic. And the patient schedules an appointment using an application, downloads their reports, and consults with their physician via an audio or video call. We also have a home care portal wherein our vision technician in the rural areas, optometrists in urban areas, they reach geriatric patients as well as the patients with the disabilities who cannot come, do the necessary tests. It's like a hybrid model Dr. Kim suggesting earlier, and teleconsultation is provided by the ophthalmologist. Purpose of teleconsultation post-lockdown has been 3 important objectives. One was to reduce the follow-up visits. This in turn reducing the congestion in our waiting rooms and allowing for the review of the reports and the new patients, also providing second opinions through the review reports. So over the past 12 months, we have completed 25,000 online teleconsultation across LVPI network. Some of the learnings. The picture of the day is an initiative to improve the imaging skills of our vision technicians to ensure effective primary eye care. The above picture is an example that with a good picture, one can diagnose and manage simple to complex problems such as eye cancer also through an effective teleophthalmology system in primary care. And these images are shared every day within the WhatsApp group of vision technician. So as a form of learning for them, as well as to motivate fellow vision technician to capture photographs, as we all know that the teleophthalmology, the sound basis is only the excellent picture. Grabby is another intelligent innovation of our innovation team. It is a smartphone attachment that captures clinical quality anti-segment pictures. The best part is that it can be used even by the caregiver with ease. And above are the examples of pictures that are taken through this smartphone, simple smartphone attachment. Similarly, folding phoropter is another innovation which can measure refraction by adjustment of the target by the patient. And portable perimeter through home device at vision centers enabled effective teleconsultation for glaucoma. Measurement of visual acuity is very important for teleconsultation purposes. In a validation study during lockdown, we found that peak visual acuity had similar results to standard visual acuity chart testing. And now we are testing in different clinical scenarios right now, even using peak by the attendant themselves. Another important telemedicine innovation is drone slit lamp or robotic slit lamp, which we developed in collaboration with Bascom Palmer Miami Group, which we are now using in our isolation room to test COVID suspect or positive patients with eye problems. So to summarize, LVP teleophthalmology model is a technology integrated, people-centered eye care solution with global and social and scientific impact so that all may see with excellence, equity, and efficiency. Thank you very much for the opportunity.
Do we have time to take any questions?
Yeah, I think so. We should have some. There are some questions, and you should you can fill into it.
So there are a couple of questions there, and let me just try to. Dr. Katta had some question. Can he ask himself, because he had a couple of? There was a discussion going on in the chat. Dr. Katta, can you ask your question directly?
I don't know whether he can ask because he will be in the attendee.
Sir, he is in the attendee, so you can.
You have to ask the question.
Yeah, you can narrate his question.
We have to repeat the question.
He wanted to know about awareness of Indian Penal Code 226 and 32 to all global medical societies. Any of the experts have any opinion about that?
Dr. Ganesh Joshi or Dr. Sunil Shroff has an answer.
I mean, in what context he's asking this question is very valid, because the Indian Penal Code, for either willful harm and so on, which may be imposed on a doctor, happens only in cases of negligence. In this, when there are two things here which we need to be cognizant of. One is that we have a disaster management act which has been passed by the government of India, which overlooks some of the deficiencies which may crop up in taking care of health of a patient. That's one. And the second thing is, as far as these penal codes are applied for willful harm of a person, it can only apply. I'm not talking about the specific of this code as such, but it will only apply if a court, if somebody can prove that willfully we have done some bodily harm of a patient. In teleconsultation, as the guidelines are very clear, that if you're not comfortable with teleconsultation, stop it and go for in-person consultation. That discretion is with you. That has been given to you to decide how you want to proceed. So I think the practice safety, and if you're not comfortable, don't practice. As simple as that.
Okay, can I add to this, Dr. Shroff? You have related very well. First of all, we have to say what he has said, that the IPC concerned with willful harm is one thing, fine. If things go wrong, people are more worried about what happens when things go wrong. What I say in this is that I'm talking about the CPA, not the IPC. IPC becomes a little too extreme. Is that most of this thing is based on documentation. And the thing about telemedicine is that it gives better documentation than day-to-day care. Now, documentation is a double-edged sword. If you're doing something right, it's very good for you, it saves you. If you're doing something wrong, it can harm you because that is caught easy. That's all. So IPC will come wherever the document is showing that something wrong has occurred based on the documentation. Yes, it can be a worry, but if you are doing something good, you are doing it, there's also a thing known as what is called the Good Samaritan rule. You are saying upfront that in the existing circumstances, I am doing my best. That is good enough.
So
you may have it.
Sir, Dr. Gogia, in addition, for all Dr. Sunil Shroff and you, I think Dr. Katta had also asked one of the question that even in physical examination, people make mistake. Mistake can happen anywhere. That is where your training is important, your perfection, and nobody can be perfect. That's why continuous improvement I learned from Shiv Kera on the leadership. But I want to tell Dr. Katta that I actually say in telemedicine and teleophthalmology at least, that We also want to do teleoptometry, but we don't treat the patient through teleophthalmology. For example, a patient from Begumpet is calling me because I have a name or our hospital has a name, even though Eli Prasad is there. I tell them, okay, you can do a teleconsultation, and based on the teleconsultation, whatever facts you have given us, we have not examined you. That's a disclaimer note I write. And I say that you have a retinal detachment and you need an urgent attention, please go to LV Prasad or any doctor, any retina doctor. The idea is that because retinal detachment cannot be treated by telemedicine and or a diabetic macular edema. That is why one of the questions were asked, I think, I don't remember who asked, whether you can use the posterior segment, and we are using the retinal photography, the posterior segment thing. So I am actually promoting teleoptometry. That means yesterday I think this Lakshmi Shinde, who is the product of Shanganetra, and Eli Prasad called me and said, sir, we are not allowed. I said, you are not allowed to diagnose, but you are being trained in indirect ophthalmoscopy, retinal photography, OCT angio, and anything. I mean, all the investigation. In all our practice, we have that, and that's what we are doing from 84. I am doing at least because I am trained in Shashaneta there. And the main thing is, I tell them, teleoptometry, you make sure you send, you are good in vision checking, refraction, intraocular pressure, and all investigation. And we will tell, for example, you are calling from a village near Pune, and I will tell that the optometrist, okay, this patient has got a diabetic macular edema, he will need injection, subject to confirmation on physical examination, medical fitness. Please go to a clinic which is about 20 kilometers away. And that's how I am propagating teleophthalmology. And the same thing I'm doing through all India, screening through teleophthalmology. Mr. Dr. Kim guided me. Don't get into the imaging and then getting the data and keeping in the cloud because they will have problem. So he said it will be advocacy and screening. That's why All India Ophthalmic Society has given me as a chairman, diabetic retinopathy screening and awareness. So we only screen. And we don't, I mean, we can guide a patient. See, every day, as our woman said, WhatsApp University, I mean, I can't believe yesterday, one of my friend, my same age group, she sent me 30 images from a neuro-ophthalmic problem from US. Then I asked me a question. So I connected a neuro-ophthalmologist because she's my classmate in Madras. Patient is in US and my neuro-ophthalmologist is in Surat. But what I did is I guided them. But finally, somebody who's examining has to decide. So I think at least in ophthalmology, at least as a retina specialist, one thing is safe is we can't treat them. We can only guide them and make sure whatever you're giving, don't give any prescriptions just like that. So I think even though the telemedicine now the law says we can prescribe, but in at least in ophthalmology we are safe. If we have a cataract, you have to come to the hospital for surgery. Still, you cannot do a tele-robotic surgery, which is I don't know when it will happen. One day it will happen. That's what I'm working on 3D and all that. But I think, fortunately, I hope Dr. Katta has answered and he can say whether anything more. But I think it's an important question. All of us have to be careful, know about IPC, but no need to be defensive. I think if you're good, and as Dr. Ganpati clearly said, listen to the patient. And even in telemedicine, that is why I don't practice telemedicine, because I don't have the patient, because I am doing organization. So I want to treat more people. So for that, I have 15 doctors who will do it. And when he has a retinal detachment, let him come to me. But I can do the organization, setting up the telemedicine like what Dr. Padmaja is doing. Imagine if I can do some 10, 20 patients or whatever time. If I have 20 doctors into 20 into 20, 400 can be done. And if 20 into 20 into 20, it can go multiple. So that's what we are thinking. I think that at least my idea of telemedicine, telehealth, regarding ophthalmology will be a guidance. Definitely investigation can be done and refer to a nearby doctor, a nearby specialist. And I think in COVID, we can redistribute the people instead of everybody crowding to Aljajot or LV Prasad or Shankar Netralaya or Arvind. Can go to individually excellent doctors are available all over, right from Kashmir to Kanyakumari. Padmaja, you want to add anything?
I think Dr. Sunil Shroff also raised one important point about white paper. So I think something like the guidelines for prescription of the drugs, what all the things that can be done from the ophthalmology through teleconsultation, what are the conditions that can be managed by teleconsultation alone. So which we laid down as a protocols in the institute, but these kind of things can be generalized so that everyone can utilize those protocols so that we have a correct guidelines.
I have a homework for Padmaja, Rajiv, Kim, and maybe Sheila John. We should make a book on teleophthalmology as a guideline. It's a funny
Just create simple guidelines. That should be enough. And then send it to the government of India, and they will, in the version 2 of the telemedicine guidelines, they will take it up, And
Yes,
that is a good role for you to play as a teleophthalmology society. You're rightly placed to do that.
So you have to prepare the guideline.
Can I interfere here? Because I mean, it's already been mentioned that I have a complete book which was made with 52 authors from across the globe. Unfortunately, it's an international book, so the costs are also international, but we can work on making an Indian version which is cheaper and available. Using that as a base, I can contribute a lot to if you want to look at a list, because currently the book is very expensive. During the COVID period, we managed to get it free. For 6 months, it was available for free for everyone to download. And anybody wants on a personal basis, I can send across a copy.
Okay, so I think I will.
There are some questions in your chat window also from the attendees. You should, I think, take them also.
Sure.
Dr. Prashant was asking any guidelines for international teleconsultation. The international teleconsultations, doesn't cover in the current guidelines. If you are, registered in that country, then you may be able to practice. Cross-border consultation has challenges, medical legal challenges of, registration of a doctor. If something goes wrong, what can happen? It doesn't, it doesn't stop you from doing it, but there are no international guidance available as such. There's also another question from him, e-consent, mandatory for all teleconsult. As we said in our presentation, that if a patient, initiates a consultation, you need to keep a record that this patient on such and such day, such a time, initiated a consultation. You don't have to take consent from him. Only in case of explicit consent, where you're giving it, if there's a caregiver, then you need to, that e-consent is mandatory to take before you go ahead with consultation. Sorry. I think I just thought that I saw this and I thought I just answered it.
And Sandeep, on this guideline to Government of India, since you are working with Government of India, can you help us? And then for the regular ophthalmologists, we can convert the same guideline into a textbook so that postgraduates and undergraduates can take it.
Okay.
We'll do that.
Tell every time my best friend Shivanandan always asks me, what did you do in COVID? Don't tell me you did 100 webinars. So I wanted to tell that I'm happy that thanks to Dr. Asta Jain and Dr. Sandeep Saxena, we have made a textbook on cutting edge vitreous surgery, and thanks to all the 108 authors. And I know it's expensive because it's Springers, it's costing 12,000, but I think we did some useful job. So now the homework with Dr. Rajiv, Padmaja, Sheila John, and Kim, and with Dr. Gogia, I think we will probably have a textbook, and which we can probably the next 2 months of lockdown we should bring it.
Yes, definitely.
We have to, ophthalmology society should take up the responsibility of preparing guidelines. Because ophthalmology is little different from other faculties, because we have to, our responsibility is to prevent blindness. So we have to reach to each individual of the country or the state where we are staying. So this is not humanly possible by physical examination alone. And the major role is to screen out people, those who are having blinding disease. To screen something, I don't think there will be that much of difficulty if you use teleophthalmology or telemedicine mechanism to do that. And if you will detect anyone having any problem during our screening process, then we can call them for detailed examinations. I think in this way, ophthalmology is better suited for tele program. Rather, I don't know.
That is why
opinion of Dr. Srauf regarding
what Dr. Patnaik. The idea is to create awareness and screening.
Yes, because we have to touch to every individual. It may not be a patient. We don't say we are.
I agree. That's why Echo India will come into play. If you see the video by Dr. Arora,
I think, sir, the best part is being we as one of your technological partner also, as well as technical assisted partner also. We have a huge linkages with the state governments. We are working very closely with the national health missions and all that. My future request would be, today we are in a launch. Definitely, this is the initiation of our session which we started. I am going to be in touch with with Dr. Subodhi and Dr. Patnaik, and we are planning to have a fortnightly systematic case-based learning model, because that will add a great value to all our ophthalmologists, even the primary care physicians sitting in the remotest area. And we will do the ample of advocacy with our network, because that is where I'm looking into the TOSI can play a big role, and All India Ophthalmic Society can play a big role with the leaders like all of you.
Thank you, Sandeep. I think it's really great. It's really great to know that, and I'm glad you contacted me instead of we contacting you.
No, sir, you people are not. I'm not going to leave all leaders like you, because I'm lucky to have association in one way or another way with leaders like Dr. Kim, you, Padmaja Madam, Dr. Rajiv Raman, and now a lot of other leaders have joined. So I'm lucky to have association with all of you, sir. Thank you.
At the right time. At the right time.
Yeah, it's Dr. Subodhi, I think. Anything? Make a concluding remarks to you and Sheila. Sheila, you have to say something, and then Rajiv and you can both conclude. Well, 7:50 it is.
Yeah, it's
International guidelines, somebody had asked whether this can be done, as Dr. Sunil Sharif has said. The Government of India guidelines applies only to India, not outside. Guidelines which has been published by Government of India, whether it applies outside, they've asked. It doesn't apply. It applies only to within India.
Rajiv,
yeah, so thanks everybody. I think it was a great session, a great learning for all of us also. And it's just the beginning. I'm sure there are a lot of questions and a lot of, as Mr. Sandeep rightly said, there are a lot of case scenarios. And Dr. Ganpati, we could not see some of the videos, but that were the living examples of how telemedicine can actually play an important role, far-fetched areas too. And looking forward for these case studies, and TOSI will take up all these, I'm sure, with the able guidance of Dr. Natarajan and Dr. Sabyasachi, Dr. Subodhi. This society will do really good. Thank you. Thank you very much. Concluding remarks.
It's over to now. Sir,
Sandeep,
you're supposed to. Yes, sir. I have a very brief presentation to update you all what ECO is, and where we play the role. And I'll tell you that where we play the role and how we have created a scenario in a big way in the country as you are talking about the telemedicine, teleophthalmology. So ECO is basically extension for community healthcare outcomes. Okay, that is the name of the organization. It started in 2003. Every life has a purpose. Every story is important. Every dream counts. Every life matters. So prioritizing access to the quality healthcare. Every doctor mission is to save a life. And as you know, sir, we are in a trying circumstances and we don't know what future holds. And we need to prepare for the worst case scenario and hope for the best. And we should consider, and the one message which COVID has taught us, that we should consider health as an investment, not as an expenditure. And that all our healthcare professionals, we are knowing the importance of healthcare as an investment, which nobody else can know that better. Healthcare workers are important, and the assets and the resources for every country. And no doubt this is a very, very crucial time. But tough situations do not last, but tough people do. And here I am looking forward that the TOSI, with the help of the organizations like Teleophthalmic Society of India, All India Ophthalmic Society, with the leaders like you, we can achieve our mission by playing a greater role in which telemedicine, teleophthalmology, and the ECO model joins hand together. They can play a big role to provide the reach and the scale for the betterment of our patients in the remotest area. Can you next? So every doctor mission is to save life, and you know that there is a long waiting time, long travel distances, and long expenses are involved. I am giving you the essence of what is ECO model, how the ECO model has started. So it has been started with our founder known as Professor Dr. Sanjeev Arora, who is basically the gastroenterologist based in University of Mexico, Albuquerque. And he thought that right knowledge at the medical care was not available at the right place at the right time. So how can we resolve this? So the purpose is, let us spread knowledge and building capacity of healthcare providers in the underserved areas. So Project ECO started with that concept, and he created a model known as hub and spoke model, where Project ECO builds a community of practice that uses adult learning techniques and based video technology to engage group of frontline health workers with a team of specialists at a distant medical center in weekly virtual clinics that focus on case-based learning and mentorship. He thought that once he was being a gastroenterologist, he was that time facing the problem that the hepatitis C patients takes. It's a waiting time is huge being in US system. And every time when they come, the huge expenses are involved. So Project ECO, he thought, let me start a hub and spoke, where hub being a specialist sitting in the clinic, he can provide the evidence-based guidelines or treatment to the primary care physicians. He voluntarily selected around 20 physicians around the arena of University of Albuquerque, and he started giving them the updates on every Wednesday 1-hour clinic, where cases discussed by the hub or even the cases discussed by the spokes, and then the discussion on the topic. So Project ECO reduces the disparity in health by moving knowledge instead of people. So we believe all teach, all learn, and our goal is to improve the lives of 1 billion people. He is our founder, Dr. Sanjeev Arora, Professor of Medicine, Ashoka Fellow. Multiple awards he won, and University of Mexico Presidential Medal also he has won in 2016. So that was the first eco clinic on hepatitis C. It started, and now, sir, I can tell you we have around more than 140 countries we have our spread, and we have put it up our trust in India also, and that is known as Eco India Trust. So Project ECO is a lifelong learning and guided practice model that revolutionizes the medical education and exponentially increases workforce capacity to produce best practice specialty care and reduce health disparity through its hub and spoke knowledge sharing networks. And the best part is we are non-financial model, sir. We have a tie-up with the Zoom platform. Our 4 principles are amplification, use technology to leverage care resources. And being leaders like you in teleophthalmology, I think this is the way forward for joining hands with ECO. And we are lucky that we are getting the opportunity with the leaders like you and with the societies like you, where we can provide the reach and the scale for the benefit of our patient, share the best practices to reduce disparity, case-based learning. To what is the difference between Zoom platform and ECO? The difference is that we start with the case-based learning model. We share with the best practices. We do the evaluation at the end of the session, pre-test, post-test, what is the compliance rate. That immediately the session gives you the evaluation also. Fine. So this is what ECO is. So ECO shares the best practice boxes, case-based learning, databases, Tele Eco Clinic. It is their Tele technology, Zoom. We provide the Zoom licenses free of cost everywhere. The purpose is democratizing knowledge. At one go, sir, 10,000 participants can join from nooks and corners of the country, and at around 200 panelists. Like today, we are having around 15 panelists. 200 panelists at one go can join, and we provide the technical support coordination at the back. If you remember, during our medical college time, we were having the medical professor rounds where associate professors, they come, they discuss the case studies. So that was the live case study discussion. And afterwards, we senior residents and undergraduates, they go for the treatment. But ECO is a virtual medical professor round. So this is what the ECO works. Can you move next? Yeah, so whether we are telemedicine, no. Telemedicine, in telemedicine, there is a one patient, one doctor, but ECO provides supports to the community-based primary care teams, and then they take the messages to these to patients reached with the specialty knowledge and expertise. So this is the difference between a telemedicine. You can see this is the first ECO clinic at University of Mexico, and at the center you can see Dr. Sanjeev Arora, and there you can see these are the initial 20 primary care physicians in the area of Albuquerque, where they have selected voluntarily, and they started giving them the evidence-based guidelines on hepatitis C. So this clinic of hepatitis C is still going on every Wednesday in that is known as Tele Eco Clinic. These are the various eco clinics, you can say, where now the spread of eco is in US. All the universities have adopted eco in a very big way, whether it's a Johns Hopkins, whether it's a Michigan University, or whether it's a Virginia University. All the universities, they have adopted eco in a very, very big way. Seeing the success and the need, they felt the near need in India, and they created a trust known as Eco India Trust. We belong to Eco India Trust, which is a not-for-profit step. We put it up in 2008, and our mission and the vision match with the Project Eco, that is our umbrella body, transforming healthcare and education in India. We are not only in healthcare, but we have entered into education also, and we have entered into livelihood. These are the various institutions: All India Institute of Medical Sciences, Delhi; All India Institute of Medical Sciences, Rishikesh; National Institute of Tuberculosis, Respiratory Diseases; National TB Control Program, TB Elimination Program, Government of India. We are the technical partner supporting them, technology partner supporting them. We are also working very closely with ICMRs. We are working very closely with various universities in the country, and PGIMR, Chandigarh, SGPGI, Lucknow. We are working very closely with the LV Prasad, Madam Padmaja Madam. We are there with LV Prasad Institute also. So these are the various focus areas in which ECO works. Now our spread is in more than 70 disease areas. You can see the current health scenario. We don't want this, that overcrowding, lack of availability of doctors. With the help of ECO model, what we want to do is that reduction in the, can you go next? That is the reduction in the scenario, and the ECO is a force multiplier, that where the message can spread and the people can take it in a bigger way. So I think ECO can play a greater role, get specialty care to the underserved area, utilizes the existing infrastructure of regional health center, reduces the movement of patients to the major towns for treatment, upgrades the knowledge of healthcare professional in regional health center. This is what ECO is looking into, the change which the ECO wants to bring. So I'll stop here now, because there are other slides, but I think I have passed on the message. The message is very clear that we are for you, we are with you, and thank you, Tele-Ophthalmic Society of India, specifically Professor Natarajan sir, for giving this opportunity to ECO India, Dr. Subodhi, Dr. Patnaik, and all other leaders which I have worked earlier with Dr. Padmaja Madam. I have already worked Dr. Rajiv Raman, Dr. Kim, and you people have seen the passion in me also in that time. Yes. Also, the same passion is going on in this ECO also, and let us try to do best with the support of all of you, and let us take the opportunity, because this is the unique thing which is available in a non-financial mode, and let us do this for the betterment of our society. So with this, thank you for giving opportunity to ECO India, and our executive director of ECO India is Dr. Sunil Anand, and our chairman of ECO India is Dr. Colonel Kumud Rai. He is the director of vascular surgery department at Max Hospital, and there is a team of 150 people based in Okla, which we are working, and today 2-3 colleagues, for my colleague Paromita, who is coordinating this event along with my IT colleague. So we are there to support you. Kindly let us know what you want, but let us have in future the more case-based learning techniques, so that message can spread for the betterment of our primary care physicians. Thank you.
Thank you, Dr. Sandeep. Definitely, we are looking for an associate to see with ECO. So now it is time to say the vote of thanks. I request Dr. Sabashis Patnaik to offer the vote of thanks to all the participants, all the viewers. We did a wonderful job today. So it is over to Dr. Patnaik for the last and final vote of thanks.
Certainly, sir, it is a great experience for all of us in this past virtual CME program that we had under the banner of Tele-Ophthalmology Society of India. So I must express my sincere thanks to Dr. Sunil Srao and Dr. Gugia for their keen interest in our program, and they are there still from the beginning of the program till now also. So we got to learn many things from them, from their experience in tele-ophthalmology. So my sincere thanks to both of them, and also to Dr. Ganesh Joshi for his interest in showing how we can help in rehabilitation of the blind people, and also take care of other aspects of the eye care. And I express my sincere thanks to them. My sincere thanks to our president, Professor Natarajan, without whose help and guidance this program would not have been successful. And also I expect a lot of future guidance from our President-elect Dr. Kim and Vice President Dr. Rajiv Raman. We have Sila Madam with a PhD degree in telemedicine. So we have a lot of talented people. We formed in a group, and we could learn many things from Padmaja Madam also. So, and their experience in LV Prasad. So I think if they can help us to share their platform some way, so any individual ophthalmologist can use that platform to have some experience of teleophthalmology within his reach. So that will be a great help from the institutions, those who are ahead in implementing teleophthalmology program. So I must express my sincere thanks to Professor Jailal, the president of IMA, who could spare his valuable time and gave us the guidance how to go about it, and also extended his wholehearted support to Teleophthalmology Society of India on behalf of IMA. So our sincere thanks to him also. And also I will be filling in my duty if I won't express my thanks to Mr. Boman Irani, who has given so much of guidance to us in a jovial and in a comical way. And those every sentence or every words he spoke has a meaning for all of us, and I think that will guide us also in future. And also he has agreed to be our brand ambassador, so that is a greatness on his part, and also Dr. Natarajan's contribution to our society. So I must thank Eco India providing this platform, and also with 2-3 interactions with Dr. Sandeep, perhaps we got to know each other very closely and very clearly also, what we want to do and what we want to achieve. And I think many of their objectives that has been mentioned to us repeatedly also, most of the things can be fulfilled through their help, because it was very difficult to get a platform like this in our previous webinars, that when we are going to use, we used to take the help of our pharma companies to get this type of support. I think this is a professional body who has many of their objectives mixing with our objectives. So we can do a great many things apart from conducting webinar. As Dr. Natarajan was saying, our role is not doing webinar. So we have to ultimately show our action or activities in the field, so that the people should get benefit out of these discussions or whatever we are planning. So thank you very much. Thank you, each of you. And I expect that any point of time, if you want any help or guidance from Dr. Srauf or Dr. Gugia, then I am sure that they will be there to help us and guide us in future also, because we are a very young organization of 1 to 2 months duration. So there are many things to be done and a long way to go. Thank you, sir. Thank you very much. I thank the audience also and the viewers who have encouraged us by participating in this program. So everybody's help is required for us to grow and to provide service to the people of the country. Thank you very much.
Yes.
Good. Thank you all.
So thank you all. I think we should end the meeting today. And hope to meet once in a month.
No technical person, Mr. Upendra, absolutely no technical hitch. And Paramita, who did all the coordination, and Dr. Sandeep, and all our TOSI. Thank you, sir. And also our viewers, and through Facebook and YouTube. Thank you all. And thanks for a patient. I know we planned for 2 hours and it went almost 3 hours. So sorry.
Yes.
And thank you all. Thank you.
Extended meeting. Thank you all for the patience you given and sitting all throughout 3 hours. So looking forward to meet again end of this month.
Right.
Thank you all.
Thank you, sir. Thank you. Thank you, everybody. Stay safe. Stay safe,
Yeah.
sir.
Yes.
Bye.
Stay home.
Stay.
Yes. Yes. Thank you all. Thank you, Sandeep and all Upendra. Thank you very much.
Thank you, Paramita, also.
Thank you, Padmaja, for voluntarily coming. Thank you, Dr. Joshi.